Good morning, everybody. We are going to get started. Welcome to the Riverside County Suicide Prevention Coalition's first annual summit. We are so grateful to have you all here. Yes, that deserves a round of applause. Thank you. We've come a long way to get here, and we're just so excited to have everyone join us for a full day of learning, collaboration, and development. My name is Diana Gutierrez, and I'm the Prevention and Early Intervention Manager with Riverside University Health System's Behavioral Health Department. I'm also a co-lead for the Riverside County Suicide Prevention Coalition. I'd also like to introduce my co-lead, Rebecca Antillon, who's the Program Director with Injury Prevention Services at Riverside University Health System's Public Health Department. And we'd like to thank you all once again for attending today's event. And so we're going to start the morning. I'm so pleased to have Supervisor Perez here with us from the Riverside County Board of Supervisors. Supervisor Perez has been a champion for mental health and suicide prevention. He's been a leader in supporting our efforts in suicide prevention from the beginning and advocates for the work of the coalition. He spearheaded the Green Ribbon Initiative in the Coachella Valley that works to improve mental health supports for the community. Please join me in welcoming Supervisor Perez.
Good morning, everyone. Buenos días. I'm very pleased to see such a crowd to come out here to meet with us, to have this discussion that's very important for all of us. You wouldn't be here if you didn't care. And I know one way or another, suicide, depression, behavioral health has impacted maybe you or someone in your family or someone you know. Let me just say thank you first and foremost to Diana Gutierrez and Rebecca Antillon for this invitation to be here with all of you. And I also want to thank Dr. Jocelyn Mesa, who's our keynote UCLA Assistant Professor in Residence, Director of Health Equity and Access, Research and Treatment, Associate Director, Youth Stress and Mood Program. Wow, there's a lot going on there. There's quite a bit of folks. I need to thank Stan Collins, Suicide Prevention Specialist, Kim Sarwatari, who's eventually on her way, I believe. I saw Jim Grisham here earlier as well, and members of our behavioral health team. I want to say thank you for this invitation because this is an issue that's very important to all of us, and many times it's an issue in which we do not respond as we should. And we know that there are more than 47,000 Americans that lose their lives to suicide each year. In Riverside County alone, just last year, there were 294 suicide deaths. And as a matter of fact, on this day, a year ago, Steve Camus from Blythe, California, also known as Chaos, took his life. Francis is here. Francis, where are you? Thank you for coming all the way from Blythe, representing your family, the Camus Colangeli family, and for the work that you're doing out there in Blythe, California. I don't know if folks know where Blythe is, but it's pretty far from here. And Riverside County is a big county. You know, it's the fourth largest county in the state of California, and we have about 2.5 million people. My district, which is the 4th district, is the largest, and it begins at Palm Springs, Desert Hot Springs, all the way down to the Coachella Valley, and it ends in Blythe, California. And in Blythe, we have a lot of needs, just like we do throughout the county of Riverside. And one of those needs is ensuring that we have access to care, and in this case, behavioral health. And you know, I started by saying that somehow we were all impacted by suicide You know, when I was a kid growing up in a barrio of Cochelita, farm worker community, one of my friends who used to live in a corner by the name of Lupito Estrada, he had struggles growing up. You know, a single mother, and my father was probably the closest he had to having someone that he could look up to. But he had challenges. He had behavioral health challenges to the point where he couldn't handle the stress. He'd get angry very quickly and was also known as a bully. And I thought it was very interesting growing up because he was my friend, but yet he was also my bully, depending on how he felt that day and what was going on in his home. Eventually, you know, we all grew up, moved on to higher education, and he stayed there in the corner house where we all grew up on Calle Avila. He had a girlfriend. His girlfriend left him. He did not know how to handle that. And so she used to work at Walmart there in Indio. He took a gun. He went into Walmart. He shot her to death. He went into the restroom and he shot himself. Could that have been preventable? Depends, I guess, on the resources, the staffing, the programs that we have, the compassion, the will to collaborate, to bring people together. I hope so, because we have to think that way moving forward. And I think it's impressive that today we have our first annual summit for Riverside County, and I expect to be having many more moving forward. I'm impressed that in the city of Blythe, the Colangeli family have come together with local leadership, with our county departments, behavioral health, to have their first march and rally, and their own outreach and education campaign as well on preventing suicide. There are too many Lupe Estradas and Steve Camus living in our neighborhoods. But we can do something about it if we choose. So this is a call to action for us to come together and think about ways as to how we can coordinate, collaborate, communicate, the 3 C's, and ensuring that we do not have to experience suicide among our friends anymore. It's going to take time. It's going to take a lot of work. There's going to be a lot of challenges before us. But I do believe, though, that if there's a will, there's a way. One of the things that I learned by going out to Blythe and talking to folks out there, and you may have the same challenges yourself. There are issues of transportation, and how do you get folks from one location to another to receive the services? There's issues of professional development, of ensuring that our professionals that are working on behavioral health are staffed up, are skilled, are knowledgeable, gain that experience, have the latest research. There's never enough money. There's never enough funding streams that we need in order to implement enough programs, cultural competency, and struggles around folks that many times do not want to speak about behavioral health issues, depression, especially among the LGBTQ community, or especially among the African American community, or especially among the Latino community, or just folks overall. Those are our realities. But let's embrace those realities and let's challenge ourselves to do more, to do better. Because I do believe that we can prevent suicide. So I ask you today, this morning, in this summit, as we're here together, to take it all in. You're the experts on the ground. You're in the nonprofit sector. You are in our school districts. You're on the county departments. You're in your own agencies. But you're working with people every single day. Let's make sure that as we're here, we gather this information and we take it home, we share it, and we take action. My name is Manuel Perez, Supervisor for the 4th District. Thank you so much for the invitation. It's a pleasure to have been here with you. I'll be sticking around for another hour or two because I'm here to learn as well. Muchas gracias.
Opportunity today to meet together for the very first time for the Coalition's first in-person event. And as such, I want to spend a few minutes this morning just reorienting us all to the origin and the vision of our Coalition. Years of planning have gone into the development of the county's strategic plan for suicide prevention. And in September of 2020, our County Board of Supervisors passed a resolution unanimously recognizing building hope and resiliency as the official suicide prevention strategic plan for Riverside County. We began the development of our coalition and had a kickoff meeting with our co-chairs, coalition members, and the community in October of 2020. The goal of the coalition is to bring together multidisciplinary teams to work towards addressing the root causes of suicide. The vision of our coalition is to work collectively in Riverside County to eliminate suicide deaths and suicide attempts and increase resources and supports. We carry out this vision by hosting quarterly coalition meetings and subcommittee meetings on a monthly basis to advance the goals of the strategic plan. So this is what we like to call our Cliff Notes version of the plan. If you want to read the whole thing, we do have it available for you. This is a nice one look at the entire plan. We've built the plan across the suicidal crisis path, which is the strip that goes across the middle of the page. And all of the dots that you see around there and all the objectives are how we built the plan following that suicidal crisis path. And those different areas and objectives are what make up each of the subcommittees. And the subcommittees look like this. So the structure includes all of these wonderful volunteers who stepped in to act as co-chairs to guide the work for each of the subcommittees. So in the afternoon, you're going to have breakout sessions, and you're going to get a chance to meet your subcommittee co-chairs, the liaisons, and the clerical support we have in place to help carry this amazing work forward. And you're going to get to hear about some of the things they've done in the last 2 years and make plans for the next year to come. So we also welcome you to chat with them throughout the day. Each co-chair is wearing a pin that identifies them as a co-chair and what subcommittee they belong to. So if you want to get a chance to know a little bit more, just find them at the breaks or at lunch. Thank you.
Okay, so now that Diana gave us a nice recap of the larger vision of our coalition, we are going to zoom in and take a look at the vision and objectives for our time here today. So just very quickly, we really are hoping to provide an overview of the Suicide Prevention Coalition and increase awareness on the current efforts that are taking place in our county. We want to provide information and resources related to BIPOC youth that are at risk for suicide. And we want to provide information and resources focused on reducing access to lethal means for individuals that are thinking about suicide. So in the afternoon, we are hoping to identify and refine subcommittee goals for the year 3 of our coalition implementation. And when we are doing all this, we just want to give you an idea of...
Thank you, Supervisor Perez, for getting us started this morning. As many of you are aware, our coalition began back in October of 2020 during the COVID-19 pandemic, which restricted us from meeting in person.
On improving the lives of ethno-racially minoritized youth and integrating sociocultural risk and protective factors in suicide prevention. You will also be hearing from Stan Collins, who will be talking on planning for living firearm suicide prevention. After Mr. Collins, we will have time for lunch, and then we will break out in the afternoon to subcommittee breakout sessions, and so you all have been identified on which breakout session that you will be attending. That will be followed by closing recognition ceremony and closing remarks. But before we get started with our first presenter, I just want to review a quick housekeeping items. So the bathrooms are located outside the double doors to your left. Just a reminder, please silence your cell phones. We don't want any interruptions or distractions during our morning sessions. And if you have questions throughout the day, we have individuals that are wearing these buttons that say, "Question, ask me." And so these buttons are identifying folks who can help you with any questions that you have about the event today or any of the facilities here. And then lastly, we do recognize that the topic of suicide can bring up some strong emotions. So we want to encourage everyone to take time to take care of yourself. And then we also want to just let you know if you need to step out for a bit, please feel free to do so. And then in the back of the room, we also have a resource table. And we have 3 licensed therapists. We have Maribel, Pierre, and Sherry, who will be seated there at the resource table, and they are available if you have any questions or to offer additional support. So, without further ado, okay. I have the honor of introducing our first keynote speaker this morning, Dr. Jocelyn Meza. Dr. Meza holds a PhD in clinical psychology and has been conducting research related to suicide for the last decade. Dr. Meza is also a certified bilingual clinical psychologist that has expertise in the treatment of adolescent and youth suicide. She has been treating youth and young adults at risk for suicide from ethno-racially minoritized backgrounds since 2017. Dr. Meza is an assistant professor of psychiatry and biobehavioral sciences, and she is at the David Geffen School of Medicine, and is an associate director in the Youth Stress and Your Mood program. Her current clinical teaching and research focus is on the development and evaluation of culturally adapted treatments for self-harm and suicide for ethnic, racial, minority youth impacted by different social systems. Dr. Meza's work in advancing mental health has been recognized by the National Latinx Psychology Association and has also received the prestigious UC Chancellor's postdoctoral fellowship. Today, Dr. Meza will speak to us about integrating sociocultural risk and protective factors in suicide prevention to help improve the lives of youth. We are honored to have Dr. Meza with us to share her knowledge, expertise, and research. So on behalf of Riverside County's Suicide Prevention Coalition, I would like to extend a warm welcome to our guest, Dr. Jocelyn Meza.
And this, I go that way.
This button.
And my slides are up. Perfect. Buenos dias. Good morning. I do have to say this is so different from a Zoom webinar, right? Just like see the little boxes. This is my first time giving a talk in real life, and I'm like, wow, this feels so different to actually see people. That's amazing. It's feeding my soul. So I'm so glad you are all here today. It's always really hard to get people to get excited and hyped up when we're talking about such a delicate and important topic. But I always say I talk about suicide with such high energy because it's part of my radical hope to make sure that we're coming together to address this problem. It's serious and it's preventable. We can come together. We need to hold on to that radical hope if we want to continue this work, because it's going to be an uphill battle. And if we don't hold on to that radical hope, we're not going to meet our goal of preventing suicide. So if you're wondering, why is she so excited when we're talking about such an important and delicate topic? That's why, because it's my radical hope in there. As you heard from my introduction, I'm a professor in psychiatry, but my heart is really at being a licensed psychologist because I get to see a lot of families and youth, primarily adolescents, that come into our clinic for suicide prevention. And one thing that I've been thinking about is that we have not really moved the needle with suicide prevention. Suicide rates are increasing. They're not improving. So we're not doing something right. What do we need to do to make sure that we're improving our suicide prevention so that we don't continue to lose so many kids, so many adolescents? In our clinic, we're starting to see really young 6- and 7-year-olds that are coming in after a suicide attempt, and that always breaks my heart to see that we're getting younger and younger kids, a lot of Black and Latino kids that are coming into our clinic. So we need to be disruptors. We need to think about suicide prevention from a different angle. What we've been doing for the last 20 years is clearly not working for our kids of color. So we need to take a radical approach, we need to take a bottom-up approach, and we need to take a ground zero approach. What is a ground zero approach? We need to go back to the drawing board, just how we are doing here, and think collectively, how can we address this problem as a group? Okay, so a few disclaimers to get out of the way. Although I'm a professor in the psychiatry department at UCLA, my views may not necessarily be the views of UCLA. I'm legally required to say that. You will be getting access to my PowerPoint slides. You're free to use them in clinical settings. If you are a supervisor, you can share them with your students. You have my permission, but they're for educational purposes only. If you would like to reuse some of those slides, please contact me for those. And we already did a trigger warning. I always like to do an extra trigger warning because we're not desensitized to this, right? We're clinicians. Although we treat this every day, it still gets to us, right? So if you need to take care of your soul and you want to take some time and step away, I won't mind. Okay. Legally, I'm required to show you where I get my funding for my research projects in my lab. Okay, so what to expect in this presentation? I'm going to be spending some time talking about some current data to highlight the scope of the problem, and then I'm going to spend some time talking about some current disparities that are often neglected and overlooked. For today's talk, I'm particularly focusing on differences by race, ethnicity, but I don't want to erase the fact that we live intersectional lives. So thinking about the youth that you treat, right? A lot of them have a lot of marginalized and intersecting identities. So I don't want to perpetuate that by focusing on that, but we just don't have enough time to talk about all of these things. Hopefully I'm invited back to talk about intersectionality and suicide. Just putting it out there. Then I'm going to spend some time talking about some current social cultural risk factors associated with suicide that are often not integrated into our care and that we need to be thinking about so that we are integrating it into our prevention efforts. And then I always like to leave on a positive note. I know I start talking about the rates of suicide, they're really alarming. And again, my radical hope is to end with solutions and to think about what are some ways forward to improve our suicide, and not just improve it, but make it more equitable, and making sure that we're not neglecting the kids that are really impacted by this. Okay. Learning objectives, what I hope you will all get at the end of this talk. First, I want everyone to have a really good understanding of what are the current prevalence rates of suicide and how they vary by race, ethnicity, particularly for adolescents, which is my area of focus. Think about and articulate some gaps that are currently impacting our advancement in suicide prevention. Describe some risk and protective factors that we can integrate, and then by the end wrap up with some culturally relevant factors that can be integrated into our treatment. All right, so I don't have a clicker, do I? A pointer. Okay, I'll move closer this way. So what you see here, this is data from the CDC that captures our current rates of suicide. So you can see on the left, that's the rank for death. And on the top, you have the age groups. And as you can see here, for kids ages 10 to 34, suicide is the second leading cause of death. If that doesn't alarm you, I really don't know what. Like, that's a really alarming fact, right? That suicide is the second cause of death for these kids, for 10-year-olds. And even more alarming is that in the last 20 years, the NIH has put so much money into improving suicide prevention, and yet the rates continue to go up. It's currently our second leading cause of death. For American Indian youth, it's actually the leading cause of death, so number one. So hopefully this gives you an idea, if you probably all of you have already seen this data, on the alarming situation. Now, if we take a closer look at causes of death, we do see some differences by age groups. They don't have data currently for 5 to 12-year-olds, but that data is becoming more available given that the rates for suicide for 5 to 12-year-olds are steadily increasing. But as you can see, for 10 to 14-year-olds, so these are around middle school, they haven't entered high school, so these are middle school kids. Suffocation is the main cause of death. And the reason why I'm showing you this data is because it has really important implications for lethal means restriction, which Stan will be talking in a little bit. And if you look at the slightly older demographics, so these are adolescents, high school age, and college age students, we see that it flips, right? So suffocation is the second method for suicide, and firearm becomes the main method of suicide. So this is really important as we think about how we do lethal means restriction with our parents and with the community, and thinking about how can we restrict access to firearms, right, or guns in the home. Suicide is also a very costly mental health issue. If you probably can't see it, but it's in the billions of dollars, $447 billion yearly. And you're probably wondering, so how do they calculate how much it costs to have this mental health problem? So they estimate these numbers based on how much it costs our medical system to treat, for example, a wound for a kid that comes into the emergency room for a suicide attempt. And it's also estimated by years lost of life and quality of life. So that's how they estimate those numbers. But as you can see, suicide is probably one of the most costly mental health issues, and we need to divert some of that money further upstream, right, in prevention, not just intervention. Most of the money right now is going to treatment, right, in ED settings and mental and other primary care settings. So we need to divert that money further upstream. I really like to always talk about this data. So if you remember the first graph that I show you from the CDC, it gives you an idea of the urgency of the problem, but it doesn't really give you the numbers at a glance to understand what really is going on. The data that I'm showing you up here is from the Youth Risk Behavior Survey. So this is the largest national high school survey that collects data on risk behavior, so drinking, IPV, and then suicide and self-injurious behaviors. So if you can see all the way at the top, nearly 1 in 5 high school students have reported that they considered suicide, so 19%. And I can tell you that this is an underestimate because these are the kids that endorse it, right? There's a lot of kids that for stigma or that, might not be enrolled in school. A lot of the kids that are high risk, for example, kids that are in the juvenile legal system that are not completing these questionnaires, they're at 3 to 4 times higher risk of suicide. So I can guarantee you that this number is probably closer to 30% in terms of how many kids think about suicide on a daily basis. And these are estimates in the last 12 months. These aren't lifetime, these are rates in the last 12 months. So the question for the first one is, in the last 12 months, have you seriously thought about taking your life or killing yourself? 19% of high schoolers said yes. 16% made elaborate plans on how they would actually do it. There's some really interesting data showing that certain Netflix shows increase Google searches for how to kill yourself. So things like 13 Reasons Why, other shows that romanticize suicide, increased searches on Google on how to kill yourself. 9% made a suicide attempt. And again, I can guarantee you that it's closer to probably 15% if we had all kids complete the survey. And then 2.5% had a really significant and serious physical injury that they needed to go to an ED or to a medical care setting. So these numbers should give you better data at a glance of what is really the problem. But we know, so these numbers are decontextualized, right? They just tell you 19% of kids had an attempt. And me, I'm a preguntona. How do you say that in English? I ask a lot of questions. And I'm like, who are those 19%? I want to know, are these the low income kids? Are these the black and brown kids? How can we contextualize the data? Because knowing that 19% of kids in high school are having a suicide attempt or thinking about suicide doesn't give me any information so that I can do something with it. So that's what we're doing in the lab. We're really trying to understand who is at risk and why. And we know that there are significant disparities by race ethnicity, such that Native American and Alaska Native youth since the 60s have had the highest rates of suicide attempts and deaths by suicide across the board. And we're also seeing very alarming increases in rates for young black boys, ages 5 to 12, and for Latinx and black girls. I'll show you a graph in a little bit on what are the differences by race, ethnicity, and by gender to give you a better idea. So this is an important problem. We need to start contextualizing suicide. So I created this table, and it's really sad that I actually had to go in and look at the data because the way that the data is presented is, like I said, very decontextualized. All they report on their yearly reports is the percentage. So I had to go on and create the data so that I could understand it better. So where do we see most of the disparities? If you look at the top row, you see that when thinking about suicide, rates are more or less pretty similar across race, ethnicity. If you go down for planned for suicide, they're more or less around the same percent, right? But once you go down to suicide attempt, that's the third column, you see that that's where we start to see some differences. And if we look cross-sectionally by gender and race ethnicity, that's where we see even larger differences. So I want to point your attention, I don't have a pointer, but imagine a red circle around female suicide attempts across race ethnicity. So 9.4% for non-Hispanic white girls, and then it goes up to 15.2% for black girls in that same age group, and 11.9% for Latinx girls. So we're seeing that the highest rates of suicide currently are among Black and Latinx girls, and we need to understand what is driving this disparity so that we can disrupt it. Okay? One problem that I have with a lot of the surveillance studies is that they often don't report rates for American Indian and for Asian American youth, so I always have to either request the data or look for it elsewhere. And this is important because American Indian and Alaska Native boys and girls ages 10 to 19, like I said, they have the highest rates of suicide, and suicide is the #1 cause of death for youth 15 to 19 that are American Indian, Alaska Native. And I have the actual rates below, so you can see that thoughts of suicide are nearly 30% for this demographic. So this is like a huge discrepancy and disparity that we need to address. And I really wanted to make sure that I did talk about these rates, although I'm not talking about risk and protective factors specifically associated with American Indian and Alaska Native youth. I also didn't want to neglect that they're an often marginalized group that we don't talk about enough. So I know there's some of you in the audience that this is your area, so I hope that we get to talk after. Okay, like I said, for Asian American Pacific Islander, their rates are actually not even reported in the yearly youth risk behavior, but you can see that they also have pretty elevated rates for suicidal ideation, so 16.9% for this demographic. Okay, so back to my comment in the beginning, like we're clearly not doing something right if we're not improving rates of suicide. Over the last 20 years, we have seen that rates of suicide have increased by 33%, which is not a small number. That's a pretty big number for the last 20 years, that it's gone up by 33%. And if you break it down by age groups, you can see that Black and Latinx females, ages 15 to 24, their rates of suicide have gone up by 133% and 125% respectively. Again, that is not a small number for rates of increasing in suicide attempts, compared to 88% among white and 61% among Asian American females in that same age group. So this should give you a better idea of like I said, the discrepancies and differences across time. And then this last point, a few years ago, the Congressional Black Caucus had a Ring the Alarm report, and where they talked about the current rates of suicide for Black youth ages 5 to 12, which is currently 2 times higher than white children in the same age group. So younger kids, we're starting to see that their rates are also going up. And this is important because it has implications for developmentally adapting the way that we do suicide prevention. And it was interesting because we're starting to see that there is a lot of momentum in addressing the Black youth suicide crisis, especially after the Ring the Alarm report. And one thing that my colleagues in my lab and I did, were like, why now? Like, trends for Black youth suicide have been on the rise since as you can see here, since the 60s, right? Oh, it's 80s, sorry. Since the 80s, like, why is it a problem now? It's like, it's been a problem. It's been a problem for the last 40 years. We just haven't addressed it, and we haven't centered that priority. And we see very similar trends, not just for Black youth, but for American Indian, Alaska Native, and Latinx youth. We've seen data consistently report increases in rates of suicide since the 90s, right? So it's not something new. It's not something that is sudden. It's something that's been going on for at least 30, 40 years that we haven't addressed. And if we don't address it now, somebody else is going to be here in 20 years, and the rates are going to be worse, right? So this is my call to action as well, for us to come together and address this. I also don't want to neglect the fact that we just had a pandemic. We're actually still going through it. The pandemic hugely impacted rates of suicide. The data that we have currently doesn't really elucidate how the COVID pandemic has actually widened a lot of the disparities in suicide. But the data that we do have shows that rates of coming into the ED or to medical services have increased since the pandemic for self-harm and for ideation. So they've gone up significantly. Current estimates is that they went up by 51%. Again, we're not really capturing here who are these kids that come into the ED. Because the kids that are coming to the ED, these are kids that have access to come into the emergency room. What about the kids that don't have access to make it into our services, into our care? Where are those numbers captured? So I'll stop there in talking about the scope of the problem. I think I've made a good effort in addressing that this is a significant problem. I see a lot of nods. We're all here because of this problem. So let's think together about how can we disrupt these current disparities that are driving these inequities, because we don't want them to continue and persist to widen further. So a lot of what we know about suicide is largely decontextualized. Even me, which wasn't too long ago when I was in grad school, most of our training for suicide largely focused on the individual level and the family level. So we were taught that substance use and depression and anxiety, they're associated with suicide. So that's what we need to treat when we see kids that are suicidal. We know that there's sometimes a lot of conflict with parents, especially during adolescence. So we have, I would say 90% of our studies, research studies, that focus on what predicts suicide has largely been in that individual and micro system. So we really haven't contextualized what is really driving suicide. So in our lab, we focus on the furthest system out there. So how does child welfare, juvenile legal involvement, culture, experiences of discrimination, stress from immigration, having undocumented status, how do those things impact suicide? Right? Because we know depression is associated, we know alcohol use, we know substance use is associated, but what about the things outside in the other context? Those things are important, and we need to be addressing those things when working with these kids, because those kids that I just mentioned, the kids that are in child welfare, that are in the juvenile legal system, those kids don't have the access to the treatment. So we need to go and meet them where they're at and make sure that we're not neglecting them. So I love this quote from Jonathan Singer. He was the previous president of the American Association of Suicide. He actually resigned last year because he got a lot of pushback for what I'm about to read. So the work of suicide prevention is grounded on the assumption that people live in a world that believes their life matter. Many people of color, however, do not see the world as their own. On a practical, daily level, society gives explicit and implicit messages that it's white lives that matter, and not black lives or brown lives or indigenous lives. So after he resigned, and the reason why he resigned is because he was getting a lot of pushback on really wanting to focus and understand, well, what is leading to the deaths of black and brown and indigenous lives. And I think this really grounds the way that we think about what is affecting ethno-racially minoritized youth. And a lot of the kids that come to my clinic, they tell me exactly what this is saying. They feel that they're in a world where their life really doesn't matter. They feel, just recently, I'm working with an undocumented student, and she said to me, I feel like I have to accept racism, that I have to accept discrimination because I don't have the privilege to fight back. And maybe the best way for me to do this is to go back to my country because I don't belong here. So these are the types of narratives that I'm hearing that a lot of students of color are telling me, and it really makes me question the way that we're addressing it. Because there I am talking about DBT and emotion regulation, and they're telling me that they really feel that they don't belong in the world, that they don't belong at their school, that they don't belong at UCLA, they don't belong on campus. So our suicide prevention should be addressing this. We should be making these kids feel like they belong and that their lives matter. So how do we do that? How do we make sure that our interventions are making these kids feel that they matter? Not just coping, right, with anxiety and depression, but making them feel a sense of belongingness, that they're not a burden to society. Okay. So why do I spend so much time, or I will be spending some time, talking about culturally relevant risk and protective factors? So if you look at how the science behind developing an intervention like DBT, cognitive behavioral therapy, this is, oh, I did not change that. If I press red, will it go back? Okay. Yeah, it's not. We all remember? Okay, there. Thank you. So this is the model that is used to develop a lot of the treatments that you are all delivering in your clinics or in whatever setting that you're in. So first we start, what is the problem? Let's collect data. The CDC does that to capture the surveillance, right? Then step 2 is, what are the risk and protective factors associated with suicide? And then we target those in our treatment development. And if you think of a few minutes back, I said a lot of the interventions that we have focus on risk and protective factors that have been tested with predominantly weird samples. Do people know what I mean by weird samples? Brownie points for whoever knows what the acronym stands for. Weird? So weird samples are Western, educated, industrialized, rich and democratic. So if you read a lot of the research studies that have elucidated the risk and protective factors, they're predominantly white samples, predominantly from middle class. So those risk factors, let me just say, they're not going to be the same for a lot of the kids that I'm talking about. So that's what we need to do. We need to go back to the drawing board, go back to understand what are the risk and protective factors affecting our adolescents, and then develop interventions that target those. Because the current risk and protective factors that have been used to develop interventions are not working, as you can see, right, by the last 20 years and the increases in rates. So that is exactly what we're doing in the lab. We're going back to the drawing board, we actually have youth that are part of our research studies that have had a suicide attempt, that have been incarcerated, and they tell us what type of data to collect. So these are adolescents that have lived experience that come and tell me what I need to do, right? Because I don't know, they need to be part of our research, right? So we integrate them into our lab, and they help us develop our surveys and collect our data, so that they're well integrated into our research. Okay, so this is just reiterating what I was saying. A lot of the work of suicide prevention is based on this premise that we need to reduce the risk factors and we need to enhance the protective processes affecting our adolescents. Okay. So what are those risk and protective factors? For today, I'm going to be focusing on Black and Latinx youth, which is the primary focus of our clinic, but a lot of my work also focuses on kids that are impacted by different systems, so the child welfare and juvenile legal system. And we know that both Black and Latinx kids are disproportionately impacted by these systems, right? So really centering the margins, right? How can we center the marginalized groups that we know are high risk, right? So I was telling you, kids in the juvenile legal system, their rates of suicide are up to 50%. So 1 in every 2 kids that are in the juvenile legal system have reported an attempt. So how can we make sure that we're collecting data and integrating those narratives into our work? Okay, so now I'm going to start and talk a little bit about what we have found in terms of risk and protective factors associated with suicide among our Latinx groups. I do want to note that when we say Latinx, that's a very heterogeneous group, so we need to understand that there's different experiences, different immigration histories that impact where a lot of people come from. And then there's also differences by generational status, and I'll talk about that in a little bit. So let's start with the risk factors at the individual level. I think it went too far. So this study was recently published, and it's among college students, and what they found was that the students that had a lower ethnic identity attachment. Like, what does that mean? That's like a handful. So these are the adolescents that feel that they don't belong to their ethnic and racial group. They don't strongly identify, they don't have a strong attachment to that identity. Those kids actually had a higher risk for suicide if they didn't have a strong attachment to their racial and ethnic identity. And if we look at other individual level risk factors, we can see that for example, generational status, I don't have time to go over all of them, but if we look at generational status, that also strongly impacts suicide. So second and third generation adolescents are more likely than first generation to attempt suicide. So first gen, I'm first gen, so first generation adolescents and college students, these are the adolescents that have both parents that are immigrants. Right, so what about being first gen is actually protective in this case? So think about a lot of these adolescents do have a stronger identity to their racial and ethnic background, so that is coming up as a protective process versus second and third generation. Immigration has also been shown to be a significant risk factor for suicide among Latinx groups. Particularly among girls, and also age of immigration. So if you think about girls that are in their teen years and that's when they move to a different country, there's a lot of developmental things going on when you're an adolescent. You're developing your identity, you're starting to develop your autonomy, and you're moving into a whole new world that is so different from yours. So we can start to begin to understand how immigration or a culture rate of stress is associated with suicide among these kids. I'll just do a clinical stop here. I always inquire about like immigration stress or immigration status, and I remember my supervisor saying, oh, I never ask about that because like I don't want that to be a factor that impacts like the therapeutic relationship. They might be fearful that I'm going to say something about their immigration status. And I'm like, well, that's why you need to build the report. That's why you need to have clinicians of color, because then they'll self-disclose. With me, like I sometimes don't even have to ask. This is something that they self-disclose because it's impacting them so much, like that student that I was just talking about. All right, so let's expand at the broader level, family and peer level. We're starting to find some interesting data that Latinx adolescents that have a parent that's incarcerated has significantly increased their ideation and attempts. And if you think about it, if you have one parent that's incarcerated, then you have less adults that are protecting and monitoring you in your environment. So in thinking about the treatments that we provide, most of the treatments for suicide integrate a parent. What do we do when the parents are incarcerated so that these kids are kept safe? Can we invite a person that they nominate, a supportive person into the intervention so that there's a caring adult with them? All right, and this is from a study that we recently published in our lab. We did a survey of Latina college students across the US, and we asked them about their conflict with the parent, but conflict that was specifically coming from cultural differences. Like if you felt that your parent really wanted you to be more Latina, but you wanted to be more independent and you wanted to have different cultural values. And what we found here was that yes, depression, so that's in the bottom, depression predicted their suicide attempts, But when we looked at the intergenerational acculturation conflict, so that's the conflict that you have with your parent because of differences in cultural values, that significantly increased the risk for suicide. So as you can see, the point at the highest chart here, those are the girls that had high depression, and they had a lot of conflict, intergeneration acculturation conflict with their parents. Those were the girls that had the highest conflict. So I want you to ask yourself, is this something that you address in your therapy? Do you address cultural differences with the parent? Is this something that you're thinking and integrating into your practice? And if we look at the broadest level, so social and community level, there is some new data to suggest that students that experience discrimination and microaggression on a daily basis on campus, those adolescents and those students are reporting higher rates of suicide ideation. And we're starting to see that the effect of discrimination is actually stronger for girls that are reporting discrimination, not just on campus, but in their community, because it's leading to a higher sense of thwarted belongingness, like they don't belong in the world, like they're a burden to society. And in a study that we did during the pandemic is we surveyed about 350 Latino college students across the US, and we asked them about what led to attempts during the pandemic. So these are actual attempts during the pandemic, not before or after. And what we found was that perceived racial bias during the COVID pandemic led to more perceived stress, which led to more depression, and that is what impacted their suicide attempts. So really interesting data here, focusing on perceived racial bias and how that actually had strong effects on their well-being and suicide attempts. I also don't like to just focus on culturally relevant risk factors, because that's like from a deficit perspective. There's a lot of protective things from our culture. So I always like to look at the cultural assets that our culture brings that could be protective. So what are some of those protective factors? Having a stronger ethnic identity and affect to your ethnic identity. So things like racial pride, feeling like I love being Mexicana, I love being Latina, really identifying with your racial and ethnic background, that has been shown to be a strong protective factor. So one of the things that we're doing in our lab is how can we have a skill to show kids how to show pride for their culture, how to show that they love being, however they identify it. And we're integrating that into our treatment. So we call it like enhancing racial and ethnic pride in the lab. Okay. Protective factors at the family and peer level, familismo or familism values. I put an asterisk because it depends on context when it is a protective factor, but for the most part, it has been shown to be a protective factor. Having a tight-knit family. So tight-knit means high in communication and low in conflict, is a protective factor. And my favorite is having one adult in your school that believes in you has been shown to be a protective factor for Latinas in particular. So think about your treatments, right? We mostly integrate parents, but how can we integrate other people that the youth nominates as their caring adult? There's this really interesting study by Cheryl King, and where she found that when adolescents are able to nominate, they get to pick who they bring into the therapeutic relationship or who they get to bring into therapy. That had strong effects 11 to 14 years later. So those kids that nominated an adult, it wasn't always their parents. Sometimes it was their high school coach. Sometimes it was like their counselor. That had a really long-term effect for their well-being. So those kids had reduced rates of suicide 11 to 14 years later. So maybe we need to think about what are some other caring people in our kids' lives that we can integrate. We always, I know, focus on parents and caregivers, but what about some other caring adults that they nominate, because they have that agency, right, to nominate who will be and show up for them. All right, this is my favorite slide. At the community and social level, what are some protective factors at the broadest context? There is some very neat data that shows that the students that are politically and actively engaged on campus, that those students, even when they face racial and ethnic discrimination, that's a protective buffer for their ideation and suicide attempts. So I always ask my students, like, what things are you engaged on campus? And sometimes they're like, well, I don't know if there are any. Okay, let's look up what are some like political or some civic engagement that you can do on campus. And if you think about being civically engaged can increase your sense of community. It also increases your attachment to your ethnic identity, right? So that's one of the things that we focus when we're thinking about activities to do for behavioral activation. I always put it like plant that seed. What are some campus organizations that you can engage on? And also there's really, the study below, what they found was that when you show students messages of inclusivity and diversity, that reduced their stress responses. Like physiologically, their stress responses were reduced when they read a message that, you know, Black and Latino students are welcome and valued on our campus. So those messages physiologically reduce their stress responses in this lab study. So think about, for example, the space that you provide in your clinic. Does it have messages of diversity and inclusion and belongingness? Because these messages at a subconscious level do impact how students feel in the room. Okay, so now I'm gonna pivot to, how much time do I have? I have 40? Okay, good. We're right on time. Okay, so now pivoting a little bit to contextualizing Black youth suicide and what our research is telling us. So if we think about risk factors for Black students and adolescents, there's some data focusing on perceived discrimination and daily experiences of microaggression, how that has been associated with thwarted belongingness, so these feelings that you don't belong on students. And we know that discrimination not only affects the student's self-esteem, it also provokes increased threat of vigilance, to more feelings of rejection, and to more physiological stress responses. In this study here, they found that the students that had the highest levels of reported discrimination, and this wasn't just on campus, it was in general their experiences of discrimination, they found that those students that had the highest prevalence rates also reported higher odds or higher risk of suicide ideation, plans of suicide attempt, and also more suicide attempt. And when they looked at differences by race ethnicity, they found that Black youth had the highest rates of experiencing discrimination on campus. And current data suggests that about 80%, and I think that's like an underestimate if it's not 100, 80% of adolescents and college students are reporting that they experience discrimination on a daily basis. So right now we're focusing on understanding if experiences of discrimination vary across contexts. So we're surveying HBCUs, we're surveying historically Black colleges. We're also serving Hispanic serving institutions. We want to see if these different contexts have an impact on students' perceived discrimination. Okay, so thinking about Black youth suicide, we know that Black youth are oftentimes in underserved neighborhoods with high concentrations of poverty. There's significant disparities in getting access to evidence-based treatment. Structural racism and discrimination impacts treatment adherence and receipt. And we know that the increasing involvements in these social systems like the child welfare and juvenile legal system further increases their risk for suicide, because it's moving them from their environment and putting them into these structures that inherently increase their suicidality or risk for suicide. Sorry, was there a question? No. Okay, so I also want to talk about what are some protective factors that have been discussed for Black youth. So this is a little small to sell, but you can see on the left side, on the bottom, we talk about protective factors for Black youth, and some of those are having strong religious and religious background or spirituality. And this is important because some work focusing on Black youth suicide prevention is providing interventions in the Black church, right? So going into those spaces where families may feel more comfortable and enhancing, like I said, those protective processes. Having strong Black identity, racial pride, a sense of connectedness, and access to evidence-based treatment. Those are all protective factors that we can enhance to support Black youth suicide. And this should be in the handout. And if we think about the continuum, so how does somebody come into our clinic, or how does somebody eventually get into access? It's actually a long road for a teen or for an adolescent to come into our clinic. First, they need to understand that there's a problem impacting them. And we know that stigma, particularly among Latinx and Black families, impact their ability to recognize that there's a mental health problem that needs to be addressed. And if we look furthest to the right, so treatment, adherence, and engagement. If there are a lot of barriers for just getting treatment in general, for suicide, multiply that times 10. So why are there more barriers for getting access into evidence-based treatment for suicide? So there was this really neat study by a team of researchers that looked at every single randomized controlled trial. So a randomized controlled trial is like the gold standard for you to test the efficacy of a treatment to show that it works. So they looked at every single randomized controlled trial to date that focused on improving suicide. There were 26 studies that made the cut that focused on adolescents. Out of those 26 studies, what they were able to find from the studies, and it's really sad, is that there was only one type of treatment that made the cut into being described as a well-established level 1 treatment, meaning that it had 2 different RCTs that showed efficacy. And that treatment, this may be part of your question, is DBT. Any DBT people here? Raise your hand if you've been trained or if you provide DBT. Okay, so for the 4 of you that raised your hand, it takes forever to get trained in DBT. You need at least 2 years to get adequately trained. It's like this manualized treatment. It's great. We know that it works at improving suicide, but it's very time intensive. So in our DBT clinic where I was trained, a family that had a kid that had a suicide attempt, they had to come to our clinic 3 times a week, so that's 3 hours, for 6 months. And then they had to pay parking that was $15 each time. And then they had the copay 3 times a week. So do the math, right? Think about the 3 copays, the 3 times that they paid for parking, the 3 hours that they had to be in treatment, and the 3 hours are 1 hour of individual DBT, 1 hour of family DBT, and then 1 hour of multi-family skills group. So that's a lot of hours that a lot of our families don't have to come into treatment. So I think now you're like, oh, now I know why getting access to evidence-based treatment for suicide is like extra difficult for Black and Latinx youth. And another problem is there's like 5 of us that are trained in DBT, right? We don't have enough clinicians of color that are trained in DBT. So how can we think about treatment that works in a different way? So that we're creating more barriers than facilitators to getting people into our treatment. I'm not saying that DBT is bad. I provide DBT in my clinic. It's great. But how can we think about delivering it in a different way? And part of us increasing access is making sure that we meet people where they're at, not having them come to us, right? How can we come to them? So, like I mentioned, some interventions, like in New York, they're focusing on providing suicide prevention in the church. Some of the work that I'm doing is I'm providing families with care at the library, at the West LA Library. Why? Because people feel safe there. They don't want to come to my clinic where it's like you have to check in and it's like kind of awkward to be in the waiting room, and if you don't feel like, you know, you belong in that setting, it's intimidating. So I've noticed such a big difference when I go into the library and the parents just feel so comfortable. Sometimes they'll bring me pan con café, and it's like, it just feels, you know, it feels more natural to be providing that care. And you also, what you do is you remove the power as a clinician and you share the power with the people that you're working with, because that's how you lead to better treatment engagement, right? Is if you share that power with your client. There is no power hierarchy. So think about what are some other settings that are in the community where we can deploy some of these treatments to make them more accessible. Okay. This video, I hope you get to watch it on your time, but it's pretty much saying what I just said, is we need to go into the community and provide these treatments if we want to make sure they're reaching the people that we wanted to reach.
There's more stigma associated with thinking and talking about, disclosing your experience of any kind of mental health issues, suicide risk. Some of these groups that are experiencing these things, they're less likely to seek care. So how do you reach that population? Reach them where they are, right? So for example, one of the things I'm part of a group, the Black Mental Health Alliance, and they've actually taken to the hairdresser store, to the barber shop, because that's where these people will show up, and they're talking to them and they're coming together and as a community talking about their feelings and experience of depression. And so it makes it easier for them to speak about it when it's in a less formal setting, and as long as there's somebody there to facilitate that process and kind of help them. I just think it's really, really important for us to reach those individuals where they are, understand that culture matters.
Right. So in these last minutes that we have together, what are some current evidence-based treatment that has begun to address these contextual factors that I talked about? There's currently only two trials that have looked at addressing social cultural factors. The first one, I'm going to skip through this because we don't have that much time. The first one is by a Puerto Rican psychologist in New York. Her name is Jovanska Duarte Velez. This is her shout out. She's the first person to have a published randomized controlled trial specifically focusing on Latinx youth and addressing what I mentioned, that when there's intergenerational acculturation conflict with your parent, her intervention focuses on that, on how can you negotiate and how can you talk about differences in culture with your kid and your parent in the clinical setting. And her intervention has really robust effects for ideation and attempts. It was literally published a few weeks ago. So really strong evidence for Latinx suicide. And then the second one is the Adapted Coping with Stress course. This was published last year. This is a group intervention specifically for Black adolescents, and parents are integrated here too. And what this intervention focuses is on teaching adolescents and parents skills for resisting, not just coping, resisting with racism across context. And this intervention was developed with the community, so they had community-based participatory research. And they also found that it was acceptable, that a lot of the community really liked it, and that it had some positive outcomes for suicide ideation. So it's great to see that some interventions for suicide are beginning to address issues of racism in the clinical setting. Okay, and these are just some of the examples of their manual on how they talk about high stress situations and how to deal with these stress situations. They're available in the PowerPoint. I just need to move forward with my last points here. Okay, so these are also in your handout here, but what can we do to make sure that the care that we're providing is more culturally responsive to our community? The first one is to engage the entire family unit when possible, and when possible to engage supportive adults. The more that you have a protective community around the adolescent and the youth, the more likely that they are to stay safe. Number two, provide youth and family members with culturally relevant psychoeducation on risk and protective factors. So not just showing them that substance use increases risk or that depression increases risk, but also talking to them about how discrimination or a culture rate of stress, like those things also have an impact on suicide. Number three, reinforce and praise help-seeking behavior so that our families can continue returning into treatment. And be flexible with therapy termination rules. So this is a specific DBT rule that if someone misses or no shows more than 4 times, you terminate them. So sometimes we need to be a little bit more flexible with some of the communities that have a harder time coming into treatment. Number 4, integrate strength-based approaches whenever possible, and importantly during safety plans. So when I go into the ED or when I do a safety plan with an adolescent, I always ask, tell me 3 strengths about you, or 3 strengths that your family sees in you, 3 strengths about your culture or your background. So really focusing on some of the strengths, not just on, so what led to your suicide attempt, right? Focusing on some of those anchors and strengths that they also bring to the table. Number 5, we're going to have someone, an expert, talk about lethal means restriction, so I won't spend too much time on that. Disclose your own intersectional identities when working with families of color. I always share with my clients and participants, I'm first gen, my parents are immigrants, I'm Latina, I grew up in a very low income family, and I always find that disclosing my own positionality and intersectionality opens the room into them disclosing that, and it really disrupts some of that power, right? Because they come and share with you some of the deepest, most hurtful things in their life, and they don't know who you are. So that's something that I think can go a long way. And also, when thinking about the skills that you're teaching or showing your clients, have some skills that include coping with environmental stressors. And if you don't have training, and for example, how do I teach my adolescents how to cope and resist with racism, or how to deal with racial trauma? Ask your supervisors or seek that training, because it's really important that you do that. Okay, I think I do have some. Do I have a few minutes for questions? Okay, good. All right, thank you. Any questions? Oh, there's there. So I built a partnership with the librarian. I literally walked in with the librarian. I introduced myself. I asked him if there was anything that I could do to build that partnership. So sometimes I would bring lunch to the librarians, and I asked them, what are some of the activities that you do? And they told me, sometimes we have reading group and we have a lot of parents here. So then I would go and I had paper and pencil, and I would ask parents, what's something that you feel is really missing, right, from your kids? And they would say things like racial trauma was a lot of things that were coming up, and if I could do groups on how to address racial trauma. So building those relationships with the community goes a really long way. And maintaining. They provided you a space. Yes, they actually used one of their main rooms in the library to provide the treatment. Yeah, it's like a big room with a table, and I go in.
We do ask that everybody speak into a microphone, please, because we are streaming. And we have a question here.
First, I want to share thank you for all the information you have given. There was one common thread that I did notice, and I want your opinion on, is that you mentioned how relevant the cultural aspect was. At what part do you feel the school should play a part in that?
I heard a lot of ooh. I think that's a really good question. So the question was, to what extent should schools integrate some of these like cultural processes or cultural things that are important? And I say that it depends, right? Because some of these schools, they're different in composition. A lot of times they don't have, for example, the capacity to have someone that can do it correctly, and sometimes it could do more harm than good if you don't have a person that understands it well. I think it's going to take some time for us to work with the schools to do this, but I think this couldn't be done in the community setting, right? So a lot of the kids that are impacted or high risk for suicide, sometimes they don't come to school. So then they're going to miss out on this opportunity. And by these kids, I mean the kids that are impacted, right, by child welfare and juvenile legal system. So I think the community and having someone that has been trained on how to navigate these conversations about culture and resistance with racism will be good. Good question.
Dr. Mesa?
Oh, yes.
Well, thank you for the presentation. I learned a lot. I took a lot of notes down as well. I really appreciate your breakdown of different protective factors, obviously family, mutuality, having an adult in a school setting, like a high school counselor, for example, or even a teacher for that matter, anybody that's an adult that's there to support our students. The civic engagement, the political activism, the community-based treatment. So this is, when we talk about systemic racism, and we're talking about the macro system, the meso system, and in an age where you have so much misinformation going out there, and ethnic studies is under attack. And you have folks out there that are critical of critical race theory.
I think that's the question, yeah.
Yeah, I think that's where that was going. What have you been able to do, or how do you, what would be your guidance for us to make sure that identity does matter, and that cultural competence does matter, and that we need to have that on an ongoing basis, not only in our universities, but as the person before me spoke about, in our school settings, elementary, middle, high school, and other settings as well. And I say that because it's every once in a while in which we have a supervisor meeting where we have folks showing up and speaking ill of critical race theory or ethnic studies in our schools.
Yeah, and I think that goes back to systemic and structural racism, right? Schools are a structure, and it's really hard to change those structures, right, that have been running for such a long time in a certain way. I haven't been able to make that much impact in the school setting because of the reasons that you just stated and that someone else alluded to. My work has focusing, like, let me focus on the community settings, right, like the park, church, other settings that don't feel as threatening, and we know welcome conversations about identity. And just to add to your point, one thing that we really need to focus on is our workforce capacity. So I've done a lot of training with like residents, psychiatrists, and a lot of them haven't had the time to reflect on their own identities and how their identities bias their treatment that they're providing. So we had a whole conversation about, you as a clinician need to understand your own identity and your biases, because that's impacting everyone that you treat, right? All the patients that are coming into your office that you may not be aware of. I have biases. We all have biases. And if we don't understand what they are and address them, that's going to impact our care. So workforce training.
We have a question over here.
I'm like, there's a voice on it.
Oh, okay. I had a quick question on if you were seeing kind of similar outcomes for biracial or multiracial and ethnic adolescents, or do this group kind of have uniquely different challenges or barriers as well?
Yeah, we haven't focused on like multiracial or biracial youth, but we know that there are some challenges with their identity formation. I don't know to what extent treatment has addressed that, but it does need to be addressed. We do see it a lot, for example, with immigrant youth that feel that they're not Latino enough, but they're not American enough, so they kind of feel like they're straddling both worlds. And I think there's a similar sense with like biracial or multiracial youth, which by like 2060, like the majority is going to be multiracial or biracial by some point. So that's, I think, something that we need to start addressing in the clinical context.
We have one over here.
Thank you, Dr. Mesa, and buenos días.
Buenos días.
I do have kind of like a combined question. I know that you have familismo as a positive, but also added an asterisk because I think I know the negative aspect. So I wanted to ask, how often you have find familism as a protective factor, and have you tried or how we can move or shift familism from that negative aspect towards the positive or protective aspect? Thank you.
Good question. Excellent question. So in the context in where we have seen the familismo, or this sense of obligation to your family, has been a deterrent or a risk factor, is when youth feel really guilty that they are not meeting the expectations of their family, and when they're in the clinic, they'll say things like, you know, my parents crossed the border with like $5 in their pocket, and I'm here struggling because somebody posted something on me on social media. So they kind of compare their struggle to their parents' struggle and feel guilt that it's not enough reason for them to be hurting. So in that sense, we see that this family obligation could be seen as a risk factor. On the other hand, where we can move it or pivot that into a protective factor is letting youth know that their family is a strong and supportive system. So we always focus with parents on how to talk about suicide in a way that doesn't increase guilt, right? It doesn't make them feel that they're not fulfilling their obligations. Focusing on familism through a framework of strength and support. So moving it to things like, you know, my family struggled a lot to be here, and they got through it, so can I. My parents have resilience that I have. So thinking about it in that framework is one way that we can understand familism through a strength-based approach.
Hi. I have a question about, so I know that family, also spirituality was a protective factor. I'm just wondering how often you've been running into, because this is something that I've been struggling with, where with my queer identified youth of color, they struggle with that because there is a part of them that wants that to be a protective factor, but they don't feel like they can be their full selves. And it's kind of like a thing that's been happening a lot. So I just wondered what your experience is on that.
Yeah, and this is why, like I said in the beginning, we need to look at this through an intersectional lens. We don't live single issue lives, right? Like we have our different social identities that interact to impact us. So that intervention that I showed you by Jovanska Duarte Velez is specifically focusing on sexual gender minority Latino youth, and how the first session focuses on identity formation and understanding the important aspects of their identity, and also how to negotiate and how to have discussions with your family about your identity. So if you have time, look at that one, because her intervention specifically focuses on that with Latino youth.
Hi. So, in the therapeutic setting, and specifically when you're dealing with Latinx consumers, how have you, reached the older generation to getting them, I guess, open to talking about these topics, especially when they're resistant because of the stigma, and kind of nervous. And two, how successful have you been with the older generation, especially when there's an age gap?
Yeah, so you mean like grandparents or parents, or just in general when there's like a age gap with the parents?
Let's say you're talking to like your grandparent
Oh.
who tells you, no me digas nada de esas cosas, estás loco, or something like that.
That's so true. And a lot of times for the Latino families, we do actually, that's why I was asking, we have the grandparents come into treatment because sometimes the parents are like working multiple jobs and they can't make it into treatment. So we do, or I do make a concerted effort to bring these older generations because they bring a lot of assets and cultural assets into the relationship. And I give them their space to also talk about their point of view and how they view the problem that the teen is having through their lens, because that's part of the cultural formulation. It's not just how the individual sees their problem through their own lens, but how the family structure views the individual's problem. So one of like my questions to the grandparents is like, how do you view your nietas or your granddaughter's problem through your own eyes? And when you offer that space for them to share their perspective, I think it kind of reduces some of that friction that there is, and also validating a lot of the things that they talk about, and spending a lot of time on psychoeducation in a respectful way, right? I always address them as señora, but spending some time to debunk some of the myths. A lot of the times they're like, es que esos de locos, you know, they're just trying to get my attention. In mi pueblo, nobody died by suicide, right? Like talking about these things and really talking about, well, you know, things are different in different contexts, and really spending a lot of time on that. But it does take a lot of time to spend time debunking myths and psychoeducation, the grandparents.
Hello. So I had it's not really a question, I guess more of just an observation. For me as a clinician, I think I always look at a whole person care approach, right? So I really see the importance of like collaborative efforts in the community. So I've noticed in a lot of the medical setting, they've started this, working along with behavioral health, with the schools to be able to really see what's really going on with that individual, because you'll be surprised what a person will say to their primary care doctor, and they won't tell me as a clinician. So I've worked a lot with getting just a release of information, explaining to the individual about the importance of just working together with their primary care, because there's a lot of things that can, affect just their day-to-day functioning. So I just, I commend the effort that you're doing, and working on a macro level, right? But it always starts individually. For me as a clinician, I just try to educate. It's always like education, going to those doctor's appointments, sometimes educating the doctor, sometimes the nurses, whatever I can do to start that process.
Yeah, we're like information gatherers, collateral information gatherers, so yeah.
Hi, I have a question generally, I guess, about, I'm not a clinician, I do more of research data side, public health, but I'm wondering what the role of like medication is for like a situation like this where maybe some of the risk factors with depression and other things, kind of like that balance of Western medicine versus like community factors, and how maybe lack of access to like more Western types of treatments might play a role in some of the outcomes that we're seeing. primarily for marginalized communities or people who might not have access to medical care in that way.
Yeah, I think it goes back to the comment from the young lady in orange, the clinician, is that we really have to build the bridge with the different providers that are working with the teen. In our clinic, we have an in-house psychiatrist that's also Latina, bilingual, and we make sure that we have a lot of communication about our patient, because a lot of times they might be seeing a psychiatrist in the community that doesn't have all the information that we have as clinicians, and then treatment plans are completely disjointed. They have very different plans that are not integrated. So we do make an effort of working collaboratively with the psychiatrist, with the social worker, and when possible with the school, right? Because sometimes they might be like a 504 that's impacting them. So we really need to be creating that community of care for them and making sure that your treatment goals are aligned. Okay, they're kicking me out.
Yeah, that will be the last question.
Oh.
Hi, thank you for asking. Thank you for taking my last question. You were talking about a specific book and an author in order to further our knowledge in regards to intersectional links and connections. I was wondering if you could provide the author and the book title.
On the book on intersectionality?
Yes.
Kimberly Crenshaw. She's at UCLA. She's a legal scholar. She's impacted a lot of my work. I can share her work, but she's amazing. She's at UCLA. Yeah.
Thank you very much.
Yeah. All righty, I can leave. Okay, thank you, everyone.
Okay, well, thank you so much to Dr. Meza for sharing her insights and such incredible information with all of us. We know that there were lots of discussion, lots of questions for Dr. Meza, and so this is a good time for us to start into what we call a pair share. And so this is where we're going to give an opportunity for you to talk to the individuals next to you and just talk a little bit about what you have learned from today's presentation, maybe some insights that you were taking away with you. And we are going to give you 5 minutes to do this. And so we are going to start the discussion now. Oh, they started the clock. Yeah. So we are going to come back, and actually, this is a really great time for us to take a break. So we are going to take a 15-minute break as you wrap up your discussion with your table mates. And after break, we will come back to listen to the next speaker. So you have about 15 minutes for break.
Okay, I'm going to bring you all back from break. Hope you had a nice rest, stretched your legs. I'm going to ask everybody to come back to their seats because we have more great suicide prevention information to share with you. Fabulous. Thank you all. That was a wonderful presentation by Dr. Meza, yes? Yeah. Thank you so much. And next up, I have the privilege of introducing Stan Collins. Mr. Collins has worked in the suicide prevention field for over 20 years, and since 2012, he served as a suicide prevention specialist on a variety of local, statewide, and national projects. Mr. Collins conducts a variety of trainings under various topics related to suicide prevention and has developed multiple curriculums related to suicide prevention, including for firearm safety instructors and firearm gun shop staff. Mr. Collins is certified as a master trainer for the Question, Persuade, Refer curriculum. He was also the subject matter expert and lead on the Stop Firearms Suicide San Diego project. Mr. Collins currently serves as the lead on a statewide means safety project funded by the Mental Health Oversight and Accountability Commission. Mr. Collins also serves as co-chair for our coalition's Effective Messaging and Communications Subcommittee. Today, Stan will share best practices, research, and guiding principles for utilizing means safety for suicide prevention with a focus on firearms suicide prevention specifically. It's a great pleasure to have Stan with us to share his wealth of experience and knowledge. Please join me in welcoming Mr. Stan Collins.
Thank you. Good morning, everyone. Thank you, Dr. Meza. You set the table and definitely put my nerves a little bit at ease. But also, I'm not sure if you picked up on, I've worked in suicide prevention since I was a pup, and through all that time, one of the things that has frustrated me when I go to the conferences and such is that it's filled with a bunch of old white dudes. So, and now I realize you got a middle-aged gringo up here to talk about suicide prevention. So, it is what it is. But I hope you're going to walk away feeling a little empowered. But I'm honored to be here to talk with you all today. So with that. We've heard a lot of content warnings throughout the morning. I want to be very clear that the content I'm going to be covering today, especially in the second half of the presentation, I will do my best to avoid any activating content, but due to the nature of what I'm going to talk about, it may be activating. So like Dr. Meza, I will not take any offense if you need to take a step, take a breath, step out for a second, but please do check in with yourselves. The one thing that I'm going to ask of you more than anything as we walk away today is please take care of yourself. Us helpers notoriously suck at asking for help, so please do what you need to do to take care of yourselves. But I hope that you're going to walk away after this presentation a little bit more comfortable and a little bit more confident in the role that you can play in suicide prevention. So on that note, I've been asked to speak to you today about firearm suicide prevention. And so we're going to talk about some of the kind of background, the means safety, why it matters. I will also share a little bit of local data. From there, we'll go into some of the principles and then focus on firearm means safety, and then we'll conclude with a little something different towards the end. I assume the green button is next. All right, so why focus on means safety? I'll give a better version of the why in just a moment, but let's start off by just acknowledging that in case you're not aware, California recently updated our strategic plan for suicide prevention in 2020. The MHS OAC, the Mental Health Services Oversight and Accountability Commission, released Striving for Zero that identified that we need to create safer environments for those experiencing thoughts of suicide. And within the Riverside County Plan, you have also identified within your wheel of your key strategies that means safety, reducing access to lethal means during times of crisis is one of the most important things that we can do to reduce suicides in our community. Now let's talk a little bit about why this matters though. Why were these strategies identified both on the state level and on the county level? The just simple truth of it is that when looking at the research and the data, that restricting access to lethal means during times of crisis is one of the single most effective strategies for reducing suicides. And when we look at it, this comes from a website I'll share with you in just a second, Means Matter, but so much of what we do in suicide prevention focuses on why, which is important. The whys are important. Dr. Meza highlighted there's a lot of whys that we've been missing over the years. But why is as important as the how. And as we go through the day, understanding that how people choose, or the suicide image that they connect to the means and methods, is a vital part of who lives or who dies. And so we need to be focusing more of an effort on the how, and spending more time in this space, as uncomfortable as it may be. And so we refer to this generally as means safety. So reducing or restricting access to lethal means during times of crisis. And one of the things that, kind of the assumptions that we make, is that someone's intent to die is directly related to the mean or method or mechanism that they choose. And the reality is that's not the case. When someone moves from ambivalence about life and death to actual thoughts of suicide, they begin to call what Dr. Mike Anestis refers to as a suicide image. And they start to paint a picture in their brain of what suicide will look like to them. And they become tied to that image. And this is, I apologize, a dark place to go in our heads, but if we were to go around this room and ask everybody, if you were to attempt suicide, which means would you use and which means would you definitely not use, that means would be different for every single person. We get tied to these things, and this term substitution is going to become important. But what we know is if we can restrict access to the most lethal means, that we can save people's lives. Or more importantly, I would argue that they can decide to save their own lives. But intent is not what determines that mean or method. It's something in their history, in their life, that has tied them to that. Now what we know, and as we'll speak about earlier, obviously firearms are extremely lethal when looking at other methods or means related to suicide. But one of the most important things to remember when we talk about suicide, and to take a minute and talk about this, one of the terms I really don't like is suicidal. Because when we say someone is suicidal, that becomes all-encompassing. That defines everything that is about that person. When someone is dealing with cancer, we don't call them cancerous, right? They're dealing with cancer. When someone is dealing with thoughts of suicide, they're not suicidal. That's not all that defines them. And we have to understand that when we use the term suicidal, if you're a hammer, everything is going to look like a nail. And so we use that term to describe someone who's every once in a while thinks about it, but we also use that term to describe somebody who every waking moment thinks about it. Now the reality is there's a huge chasm between those two people, and we need to respond to them in completely unique ways that are specific to their needs and their wants. And in fact, I got involved in this work after losing one of my friends to suicide, and it wasn't until I started working in firearm suicide prevention that I really put the dots together that he also died by firearm suicide. But when he died, I thought that suicide was about wanting to die. And therefore, suicide prevention was about convincing people not to die. And it wasn't until I went through my own struggles that I realized that suicide's not about wanting to die, it's about not wanting to live. And that sounds like the same thing, but they're two very distinct things. And again, there's a huge chasm between those two. And therefore, suicide prevention is not about convincing people not to die. It's about helping people find their reasons for living. And when we look at the data related to suicide, what we find is that 70% of people who make a suicide attempt will not go on to attempt again in their lives. And so this goes back to this idea of suicidal. It's not all-encompassing. There's opportunity for post-traumatic growth. And in fact, 90% of people who attempt suicide will not go on to die by suicide in their lifetimes. So this should give us hope. This should be positive news, but we have to stop treating individuals who have had thoughts of suicide or experiencing or have experienced thoughts of suicide like this fragile piece of glass that needs to be held with baby gloves for the rest of their existence. And this is important, again, when it comes to means safety, because if we can get somebody to survive that first attempt, they're more than likely not going to attempt again. They're more than likely not to go on to die by suicide. And numerous studies have demonstrated that there's a lack of substitution. Again, people don't switch, and if they do, it's to a less lethal means, and we'll talk more about that in a second. But one of the kind of foundations for all of this work is the Means Matter website out of the University of, or Harvard University. I think it's the Chan Public Health Department. But they really were one of the forebearers in bringing means safety and research and bringing all this together into the conversations that we need to be having. Now, the effectiveness of means safety has been demonstrated in numerous studies, and I'm not going to bore you by taking you through each of them. And I'll talk more in just a second about how we have to get away from this mentality of kicking the can down the road. But what we know is that if we reduce access to the most lethal forms of suicide, not just suicides using that form go down, but suicides overall went down. And this has been replicated across studies, across countries. And sometimes it's looking at the little things. For example, and again, I apologize if this is activating, but For example, how many actions does it take to attempt suicide using 100 pills in a bottle? You unscrew the cap, you pour them in your hand, you swallow the pills. 3 actions. How many actions would it have taken if those 100 pills were in a blister pack where you had to pop out each pill individually? That's 100 different actions. Now, that's not necessarily a physical barrier per se, but that's 100 intentional actions I would now have to take towards a suicide attempt than the 3. Or what if you say, well, what's the point in keeping the guns locked and keeping the ammo separate if I'm the one with the combo to the safe and I'm the one with the keys to the lock? Well, now instead of picking up a gun and pulling the trigger, I have to go get the key, I have to go unlock the lock, I have to get the ammo, I have to load the gun. And it's all these little speed bumps. And one of the things, and I'll talk more about this later, but we have to stop waiting for perfect. We have got to understand that there's a philosophical element to suicide, and that every one of those speed bumps, every one of those moments of hesitation is an opportunity for someone to make a different decision. Because when you talk to people with lived experience, when you talk to attempt survivors, there is a level of ambivalence right up until that moment. And so by helping to keep people safe through means safety, we can be really effective. So the big kind of response to this is, well, won't people just find another way? If you take away the pills, they're going to get the gun. If you take away the gun, they're going to go to the bridge. If you put a barrier on the bridge, and we keep kicking this can down the road thinking, well, it's just inevitable, right? And again, studies have shown time and time again that people, if we can restrict and ideally restrict, but at the very least put speed bumps between someone who's experiencing thoughts of suicide, someone during those periods of overwhelming pain, and access to those means and methods, that they likely will not go through with the attempt, because by the time they get access to it, that crisis will have passed. And if they do substitute, that the substituted means will be much less lethal. So what can we do? We can put people in a safer environment. We can put a physical barrier between the person and access to those means. Or we can put speed bumps. We can put time and space between that person. One thing that a lot of people don't realize is that, again, going back to this idea of suicidal, that someone may have thoughts of suicide or experience that for months or even years. But the actual moments where they're capable of suicide, and this term capability comes up a lot in the research and in the theories related to suicide. When someone is actually capable of making a suicide attempt, because that pain is so intense, are typically short-lived. On average, we guesstimate that it's about 30 to 90 minutes. And so one of the things to remember, if you're ever sitting with somebody as they're talking to you about their thoughts of suicide and they really feel like they're capable, is that time is on your side. To let the clock tick by, to remember that people don't spontaneously combust, and sometimes just by talking about our thoughts of suicide, we become less at risk for suicide. So we can do all of these things, and again, we can make the means less lethal, again, by removing that substitution. So these are all just laying the groundwork for the conversation we're going to have around firearm means safety. Now, when it comes to suicide in general, when you look at some of the means safety efforts that are out there, what I found is there's kind of a few key components. One of them is that we just make the public aware. We put out brochures, we put out PSAs, maybe posters, and we try to get them to have conversations about suicide. First, recognizing the warning signs, having the conversation, referring that person to help. But we need to do a better job of empowering the average individual to understand that they can have a role in means safety, that they can have a role in helping to protect either themselves or their loved ones from the most lethal forms of suicide. And we also can provide gatekeeper trainings. We recently launched an effort on one of my other projects working with pharmacists from across the state, understanding that they are one of the most accessible forms of medical providers that we have. I could call my doctor right now. I'm probably not going to be able to see him for a couple of days, but I can walk down the street and speak to a pharmacist in 15 minutes. So empowering them. And not to be overly dramatic, but they are giving means and methods across that counter. They should be trained in the awareness around suicide risk. I have friends and loved ones who have had to partner with their pharmacist, either for their own safety or the safety of their family members, to flag or put notes on their record that no, this prescription should not be filled early. And there's different steps we can take, but also, as Diana mentioned in my introduction, working with firearm instructors. So getting it out of the mental health community, coming to the firearm community, but getting the trusted source within the firearm community to say, no, suicide prevention is something we need to be talking about. 6 out of 10 firearm deaths in America are suicides, not homicides. And throughout all the conversations we have about mass shootings and gun violence in general, how often do we hear it related back to suicide? Very rarely, I would argue. And yet 60% of firearm deaths are suicides, not homicides. So working within the gun community, the firearm community, working with gun shops owners, their staff, and firearm instructors is hugely important. And again, empowering family members and friends and loved ones to understand the role that they can play. And throughout all this, and I'll circle back to this in just a little while, lethal means counseling. I imagine there's one or two mental health professionals in the room or medical providers holding ourselves accountable to be willing to have that conversation, to be comfortable to have that conversation. And so we'll talk more about how these steps fit in when it relates to firearm safety here in just a little bit. All right, now we also have to be guided by the data, right? We have to use the data to inform our efforts. And you heard a little bit of it, but the the state strategy identifies that we need to do a better job of data collection. Now, you are fortunate here in Riverside County that you guys keep awesome data. So I'm really impressed with Riverside County and the data that you collect. As uncomfortable as the data may be, we have to look at it. And I hope this isn't too hard to read from back there. But that top line that starts on 101 on the top left and goes across the top for the most portion, that's where we see the firearm deaths in Riverside County over the last period of time. You heard Dr. Meza earlier also talk about hanging and suffocation, which is the orange line directly below it. One of the hard parts when it comes to hanging and suffocation is that that's actually one of the areas where we're still trying to figure out what to do. It's really hard to restrict access to ligatures and items that can be used for hanging and suffocation. And so one of the realities is that as much as I'm always the proponent for responding to suicide risk in the least restrictive setting, if that is someone's preferred or chosen mean and method, we probably do have to be a little bit more intensive in our response. We probably do have to. It's very difficult to ask a family or a friend to have 24-hour surveillance. In fact, one of my frustrations, and I would love to see this change, is that you can go online and Google for hospitals, or care settings, and you can buy a suicide-safe sink, a suicide-safe door, a suicide-safe door handle, and yet none of those are publicly accessible. An individual sink costs about $600, $700. Why is there not a market for? I certainly would spend a couple $100s to safeguard my home if I knew that it might reduce suicide risk for somebody, but we're just not there yet. And so we need to put pressures on these types of industries to say, hey, just stop making money off your $600 sink because you're selling it to a hospital. And how can we help to safeguard homes by bringing these things in? So I don't know, I'm pushing a boulder up a hill, but we'll see what we can do. Nonetheless, it's fairly easy to see just how significant firearm suicide deaths are in this community, and also just the risk related to firearm suicide deaths. Again, a large portion, if nearly all of firearm suicide attempts result in death and are extremely lethal, and this is going to be more prevalent. This breaks it down, I apologize. This is for males who are disproportionately impacted by firearm suicide. As opposed to females, we see those portions go down, but still fairly significant. This is especially true among females who are either current or retired first responders, as well as military. We see a significant increase in firearm suicide deaths in that population. Again, this is one of those possibly activating places, and I apologize for that, but just looking at the means of attempts. And again, you see the firearm is represented by that little green stripe on the bottom for male and non-existent in the female population. If someone chooses firearms, the reality is, unfortunately, the risk of lethality is huge, and that's why so much of the means safety efforts have been focused. As you'll see in just a moment, or right here actually, here it is. If we could make even small gains in reducing firearm suicides, we could have significant gains in reducing suicides overall. And so this is by no means a conversation to attack gun owners or to attack firearms. This is just looking at the data, looking at the math, and realizing that if we're going to put all of our energy into one space, let's talk about firearm suicide. Let's bring the firearm community into it and make it a responsibility and accountability part. And let's do our end on the mental health side of things to reach out to them and partner with the firearm community. And so therefore, that's why I was asked to talk about firearm suicide. Excuse me, just one sec. All right, so let's talk about it. Again, apologies if any of this is activating to anybody. As I mentioned again, the state strategy identifies that we need to do a better job in gaining access to the firearm community and having them as partners. And for us to make an impact, we have to do a better job here. Now, this is one of the, in working with the firearm community, and I should also have mentioned that I come from the firearm community. My mom, my dad, my brother, everybody in my family is a cop except for me. So I grew up, and looking back, I think back to just how unsafe my parents were with their firearms as a child. There was a gun on top of the fridge, there was a shotgun in the closet. I mean, no means safety whatsoever. But I also grew up in a culture where it was a tool. It was not a weapon. It was a tool that they needed so that they could come home at night. Nonetheless, completely unsafe, and I lecture my parents about it all the time. But the reality is that having a firearm in the home does increase suicide risk, and that's a hard pill to swallow for people in the firearm community. That how can, just because this one thing is present, how can that automatically increase my risk? But that's what the data, that's what the research shows us. So I want to talk a little bit about some of the work related to firearm suicide and some of the efforts that are ongoing. As you look across the nation, this is an area that really has only been tapped into just a little bit. You see a few different samples from across the board, and I'm going to take you through a few of these. But I don't think anyone's got it perfect yet. So before we get there, though, when we talk about some of the resources, some of the samples, or examples, I want to talk a little bit about the data and dispel one of the big myths related to firearm suicide. Now, for a long time, because we didn't have the research, and one of the, again, frustrating parts for me in my field is if you look at the number of studies that have been done on suicide compared to other leading causes of death, it's a drop in the bucket. We have got to get more funding for suicide prevention, especially among diverse communities. But when looking at the data, we had always thought that the average time that someone owned a firearm before they used it in a suicide attempt, which likely resulted in death, was about 7 to 10 years. And a couple years ago, they came out with a study that completely turned that upside down. And what they found is the majority of suicide deaths were within a year of purchasing a firearm. And this is significant for a variety of reasons, but if you look at from gun owners to non-gun owners and the percentage of suicides by firearm to the percentage of suicides by other means, a couple things I want to point out. The significant number, and one of the, there's a pointer? Oh, there is a pointer. Sorry, Dr. Meza, we didn't point that out to you. I got a pointer, you didn't get a pointer. I got a pointer. And she's a doctor. All right, so gun owners over here, so the N value is significantly smaller than the N value over here. But the number of firearm suicides. Now, another thing I want to highlight here too is that owners of firearms are not the only ones dying by suicide by firearm. And that, in fact, the numbers were fairly significant of non-firearm owners dying by firearm suicide. So just not owning a gun doesn't mean that you cannot get access to a firearm. But one of the things I want to point out here, and this is, again, I apologize if this data is hard to read. You're welcome to have my slides if you care to. But over half of the suicides that occurred in this 12-year longitudinal study occurred within the first 365 days of firearm ownership. Now in California, we have the 10-day waiting period, which I fully support. But it wasn't just, obviously it wasn't those 10 days where we saw those significant numbers. From 11 to 30 days, 31 to 90, and then about half from 3 to 12 months on. And one of the reasons why this is so important is right here. If you look at the period of time that we've been experiencing, this is the increase or spikes in firearm sales over the last few years. One is Sandy Hook. Another one is the shooting that our neighbors in San Bernardino experienced, the Parkland shooting. And the amount of firearm sales that spiked during COVID-19. And if you look out into our communities and you think about the data that I just presented, the majority of firearm suicide deaths happen within 1 year of purchase. And then sorry, I broke the button, I think. And then you go back and you look at how many firearms were newly introduced. Oops. Keep pressing the wrong button. I apologize. Oh, no, now I'm just pressing buttons. That's what I get for bragging about my laser pointer. Okay, now I'm just messing everything up. I'm going to stop pressing anything for a second, see what happens. I think we're good. All right. So that spike. Again, knowing that many people had firearms newly introduced to their homes, that level of risk that we just talked about. Now, the other concerning part about that is that these folks were buying firearms at a time where they couldn't take a firearm safety course. They didn't have access to that wealth of knowledge within the firearm community, firearm instructors. They didn't have access to a lot of the places where they might go to safely store firearms. And so this is something that we just have to be aware of in our communities, that it's not too late for us to go back and catch up, partner with local gun shops and say, hey, can you reach out to the folks? And this is a novel idea, but what about the idea of having a gun shop partner with their community and host a firearm suicide prevention or suicide prevention seminar? Why not? Again, as gun owners, we have a responsibility to be accountable to this work, and if looking at the data and knowing again that 60% of firearm deaths are suicides, we have to be concerned about this and we have to be paying attention. We have to do a better job. Now, one of the groups that is doing tremendous work out there is the Education Fund to Stop Gun Violence. And I want to encourage you to go to their website, Prevent Firearm Suicide, and then the abbreviation is kind of rough, efsgv.org, Education Fund to Stop Gun Violence. But I want to take you through a little bit of their thought process. So I explained this a bit earlier when I was going through the principles in the background. But one of the things they talk about is that why means safety? Why means restriction? There's more than likely going to be a delay, and that delay will allow for that crisis to pass. If that's not the case and there is substitution, that substitution is more than likely to be to a less lethal means, especially if we're talking about firearms. And ultimately, the suicide crisis will pass for most. Again, going back to that data, about 70–90% of people either won't attempt again or won't go on to die by suicide. We will ultimately see those suicide rates drop. Now, on their website, they identify there's different levels. We heard from Dr. Meza earlier talking about how the different rings of how we can impact individuals. And so oftentimes, yeah, we can look at the societal level. Here in California, we have the Gun Violence Restraining Order, which I'll speak to a little bit more in just a, actually, I'll talk to you about it now. In case you're not aware, there's something called the GVRO, the Gun Violence Restraining Order. And the legislation has been expanded. It used to be restricted to immediate family, and now it's expanded to friends and to coworkers, which some folks disagree with. But that is one avenue for individuals, but it is one of the most intense. I think we have to be very cautious when we're looking at taking someone's rights away. And whether that's taking their firearms away, whether that's hospitalizing somebody via 5150, we have to be very cautious in taking someone's rights away, acknowledging that that could present a huge risk factor. That could be, we could inadvertently drop the precipitating event in that person's life that would push them over the top, or be the straw that broke the camel's back. And the GVROs were actually initially created with the intent to prevent mass shootings, and the reality is, more often than not, they're being used to prevent suicides rather than harm against others. In our community, though, we can partner with gun shops. We have to stop this us versus them mentality. There is not a single firearm gun shop owner that I've ever worked with that is comfortable with the idea of selling someone a firearm that ends up being used in a suicide. They don't want that. That is not why they got into this work, and we have to understand that, yeah, they run a business, and yeah, we may not agree on everything from a political standpoint or firearms, but understand that they are humans. And in fact, when I was working in San Diego on the gun shop project down there, 99% of the gun shops that I went to immediately signed up to do this work with us, that partnered with us. And 100% of them were suicide loss survivors. They want to help us in this work. They don't want people to die by suicide, and we have to look at them as partners. So we can partner with them in our communities. And this is something I'm really going to spend a lot of my time remaining focusing on. We have got to do a better job at the relationship level and at the individual level. At the relationship level, one of the biggest disservices we've done in mental health, and specifically in suicide prevention, is that we built an ivory tower and we stuck suicide prevention way at the top, where only a handful of people are possibly capable of preventing suicide, when in reality it's the friends and the families that give us our reasons for living. We have got to start dispelling the myths that we have created around suicide, that only a certain group of people can prevent it. Nobody has sole access to our hope and our pain, and we really have got to do a better job empowering friends and family to have these conversations with their loved one. That's where the real work happens. But I can't say this enough, we have got to start empowering the individual. So much of suicide prevention through the time that I've been in this field has this whack-a-mole mentality, that we need to teach people to recognize risk in other people, and we so rarely talk to the people who might be experiencing these thoughts themselves. But what do I do? What if I'm not worried about somebody? What if I'm that person? We have got to do a better job empowering individuals to help find their reasons for living, but also to make themselves safe. And so looking at all these different levels are the things that we need to be doing for firearm suicide prevention. All right, so talking about the gun shop project. So this actually started back in New Hampshire, and it was started by, it was actually a partnership from the local NAMI chapter, National Alliance on Mental Illness, with the local gun shop. The gun shop owner had come to the local chapter and said that he had found out that one of his customers had died by suicide from a firearm that he had purchased in that store. And they created the Gun Shop Project. It's now been replicated in numerous instances across the country. Now with that, it has to be customized, right? So a few years ago, we went to bring it to California, and we looked at the brochure, and we're like, oh, let's just adapt it to California. Now New Hampshire is live free or die. Needless to say, rules around guns are a little bit more, let's say, provocative than maybe here in California as far as who can and who can do what with their firearms. So we had to adjust it a little bit and look at how things are different. But we brought the project to San Diego. And when we brought it to San Diego, we worked with local gun shops. We brought them the brochure. We said, hey, what do you think? What do you like? What don't you like? We made them partners in the development of the material rather than just showing up one day and saying, hey, will you show this brochure? We had conversations with them. That's how I found out that they were lost survivors. That's how I found out that they wanted to be part of the solution, not just part of the problem. They want to partner. One of the gun shops in San Diego even offered a discounted storage rate for any individuals who wanted to store firearms at their location. And so we used the code Gun Shop Project. And so when they came into the gun shop, if someone used the term Gun Shop Project, they automatically got a discount on their storage rates. And so it didn't make the person feel uncomfortable, it's just and they didn't ask who was having risk of suicide in that person's life. And this is where another one of the areas, I'm going to talk probably more about this as I go. One of the things we have really got to do, as I said, we got to stop waiting for perfect. We have got to stop being afraid of the boogeyman and fear, allowing fear to guide our work. A lot of people say, well, we can't do the gun shop project because what happens for the liability when the gun shops give the firearms back to the individual? So we're not going to help people be safer because we're worried about what happens on the back end. And so we just freeze. And looking at, again, by understanding that someone, when they bring firearms into a gun shop for storage, they don't need to give a description of who's at risk or why they're at risk. There's no liability for that firearm dealership to put those back on, aside from running a background check, which is required. But the gun shops were very interested in this work. Again, 99% of them signed up to display the brochures and the posters and continue that relationship. We took it a step further, worked with one of the gun shops to also partner with their firearm instructors. So now if you go to a 3 or 6 hour course at Poway Weapons and Gear down in San Diego, you're going to get 10 or 15 minutes from your firearm instructor on suicide prevention. And he's going to let you know, for all the risks that we're going to talk about today, unfortunately the most deadly risk that you have by bringing a firearm into your home is by suicide of you or your loved ones. And that's a very powerful statement to be coming from a firearm instructor and that trusted source. So again, teaming up and partnering with them. Now, an organization that has done tremendous work in this area is the American Foundation for Suicide Prevention. A few years back, they broke ranks with most of the suicide prevention field and partnered with the National Sports Shooting Foundation. And they developed these materials. They created a brochure, and one of the things I was really impressed by is they created a post-vention guide. So a post-vention guide for ranges on how to respond after suicide on their range. A lot of people don't realize that unfortunately those are sites where suicides frequently happen, but they also don't realize that there are things that gun ranges can do to implement protocols to help reduce that risk of suicide. And we don't speak openly about them because we don't want people to know how to deviate around those. But these are some phenomenal resources that are available. So I wanted to let you know about those. Now, looking across the nation, and I'll talk more about our statewide efforts here in just a second. There's a lot of really cool work being done in states like Colorado and Tennessee, Utah, and again, working with the firearm community and having them partner with us in this work. This PSA on the left is your safety on, is really bringing that awareness around firearm safety and as it relates to suicide. And then in Colorado with their Firearm Safety Coalition, it's awesome. They have an interactive map. So no matter where you're at in the state, you can go onto this map and you can identify where's a local gun shop that you could go and store your firearms at just to get them out of the home. Again, not get rid of them permanently, just until things mellow out a little bit. Now here in California, I'm excited that in just a few weeks, shortly, we will be launching a statewide means safety website. Yana Shares-Patowski has been tremendous. Me and her have had I've had the pleasure of working with her for the past decade. Her and her team have been tireless in working to create this website. So once we have it live, we will definitely share it via the Riverside Suicide Coalition out to you. But this website is really, again, taking it out of the ivory tower. This website is public facing. It's intended for community members. So empowering friends and family to say, how do I make my home or their home more safe for them? But also in speaking to the individual, if you're having these thoughts of suicide, what can you do to empower yourself to stay safe? So this is what the website looks like. I wanted to take you to the means safety buckets, though. Within the website, there's a page on firearm safety, there's a page on overdose and poisoning, there's a page on suffocation and strangulation, and then signage and other forms. So within each of these pages, too, there's one for in the home, and there will be another page for professionals. So when we get to the overdose page, there's a page for in the home, what are some of the precautions you can take, and there's one for professionals or for pharmacists. What can they do to be safer around suicide prevention? So I encourage you to spend some time exploring this website when it launches here in just a little bit. And then from there, I wanted to spend just a few moments focusing on the firearm suicide prevention page. So again, we have the in the home page for individuals, how to safeguard your home, and then for retailers and ranges, what can we do in relation to making those gun shops be partners in our communities. And so within the website, we also came to this from a lived experience kind of opportunity, realizing that we're not, again, getting rid of this us versus them mentality. And so we also wanted to start at the least restrictive way. We didn't jump straight to the GVROs or having law enforcement engaged. We wanted to have people start by just learning the warning signs. When should you know when to be concerned? How do you have that conversation with a loved one and say, hey, are you having thoughts of suicide? Can I talk to you? From there, moving into having conversations and considerations to getting the firearms out of the home. So again, when this website launches here in a couple weeks, it will be available both in English and in Spanish. So we're really excited for just bringing this information out to the community, dispelling the fears around it. Now, one of the points that we really emphasize on this website is what's called the Safe Harbor Law, or what we refer to as the Safe Harbor Law. Now, I mentioned earlier when we brought the gun shop project from New Hampshire to California, we're like, oh man, we really got to change the verbiage, because again, in New Hampshire, they don't care what you do with your guns. California, we're a little more particular. But just a few years ago, and this is probably going to be a note to many of you, is that California actually updated the penal code. Let's say a few years ago, I'm just going to use Dr. Meza, because I think she just stepped out, so I'm going to pick on her while she's gone. Let's say me and Dr. Meza are friends. And she's worried about me, and she comes to me and she says, hey Stan, I know you've been going through a tough time, I know you've been going through this, I know you've been going through that, why don't you let me hold on to your guns for a little bit? If she took my guns to her house, that would have been a felony both for her and for myself. The penal code was updated, though, to give an exemption. And as you read on the screen, that it's no longer illegal if someone is voluntarily giving up their firearms for the purpose of suicide risk to a person who is not prohibited from owning firearms. So they have to have a firearm permit, they have to be able to store them safely, ideally in a safe with a lock, but at a minimum in a lock. They need to be stored unloaded. And that individual, so Dr. Meza would now, it wouldn't be illegal, but she would only be able to take those guns to her house and only be able to transport them back after the crisis has resolved. This is the only 2 times she gets to transport those firearms, but nobody knows about this. I would talk with local law enforcement agencies. I had to call out a few police chiefs, which was really hard for me. He's like, no, that can't be accurate. I'm like, chief, really sorry, but this is the case. I even called the Bureau of Firearms. They're like, I don't know if that's true. I finally got on the phone with somebody from the Attorney General's office for the state of California, and they're like, I didn't even know that's a thing, but yeah, it checks out. It seems like it's a thing. So here's a law that we're going to be really emphasizing in that website to let people know that they have this, that they're empowered to do this. Because again, this is the most real world, in my opinion, application of firearm safety or firearm means safety and getting those firearms out of the home. 2 people have a conversation, one of them that has trust and rapport and probably years of relationship with this individual says, hey, I'm worried about you. I don't think you're safe. Are you having thoughts of suicide? Hey, why don't you let me hold on to your guns for a little bit? And there's other steps that you can take short of this. You could put a lock on the gun and then the other person takes the key. Or maybe the person just takes the ammo. Or if the person is familiar with firearms, disables it by taking out the firing pin or whatever it is. But I really think it's important that we start sharing information like this. Information like this should not be held behind locked doors. We have to be informed, and we have to do a better job of communicating how can the average person learn how to implement and incorporate means safety into their lives during times of crisis. So I wanted to share that with you all, and hopefully we can, continue to do work in this area. Now, another key element of means safety is having conversations with professionals, counseling on lethal means. I know Dr. Meza mentioned this earlier, but I want to take just a few more minutes and talk about this. Now, counseling on lethal means is one of the big gaps that we have, whether it's healthcare or behavioral healthcare. And a lot of times that is because the individual the professional who's having that conversation, especially when it comes to firearm, isn't familiar with that mean and method. And so one of the other things that we're doing with the gun shop down in San Diego is cultural competency trainings, where they're bringing in mental health professionals to go through a firearm safety course, because it's really difficult to talk with somebody about firearm means safety if you've never held a gun. Now, I'm not trying to push firearms on you. I'm not trying to say you're going to enjoy it or any of that. But what I'm saying is we have to at least be culturally competent. We wouldn't go into any other community without some sort of cultural humility. So why do we think that we can go to the firearm community and go to firearm owners and think that we can have a culturally competent conversation if we have no bearing or understanding of what they're going through? So we have to go and we have to look at what are the conversations that we can have. But these conversations have to occur after trust and rapport has been built with that individual, and when we ourselves have competency. So some of the key things about counseling on lethal means and some of the trainings that are out there, it's going to look at, what are some of those techniques, what are some of the skills that we can bring to it. And it's the little things. For example, let's say a mental health professional in a school setting. Their kid's been identified to be at risk for suicide, and their parents or guardians come in, and the first question the counselor asks is, oh, well, do you have firearms in the home? That can come off as a very judgmental statement to that parent or guardian, and they're likely going to say no just because they don't know what the repercussions of being honest with you are. Instead of just simply asking what if you skip question 1 and you go to question 2 and you say, hey, where do you keep the firearms in the home? If they don't have firearms, they're going to, oh, we don't have firearms in the home. If they do have firearms, you didn't start with a judgment statement. You started with a conversation about what can we do to keep your kiddo safe? What are the access to the resources that I have to help empower you to do that? So, a call to action to any of you who have not been through this training. It's available for free. It's online, 2 hours. It's called Counseling on Lethal Means. It's part of the Zero Suicide Initiative. They're actually in the process of developing a version of it for crisis line workers. So that will be out in the next couple months. But Counseling on Lethal Means. Please carve out a couple hours sometime in the next couple weeks to put yourself through this training, whether you're in healthcare, whether you're in behavioral health. But we need to have more and more people being willing to have a conversation about how people can be safe, empowering them to be safe, and being competent to come to this conversation with humility so that we're not scaring people away. Because when you talk to gun owners, a lot of times they don't want to seek help for their mental health issues because they're so worried about losing their guns. We have got to do a better job of dispelling those fears and those myths. Another thing that we need to do a much better job of is safety planning. Safety planning is one of the most evidence-based skills that we can do to, again, empower the individual to decide to stay safe, to help that individual decide to find their reasons for living. They just updated the website. Dr. Stanley and Brown are the ones who really are the key minds behind the safety planning intervention, but suicidesafetyplan.com, they just updated the website, as I mentioned, with vignettes and take you through all the different steps. And if you're not familiar with the safety plan, it starts by first recognizing our signs of crisis. When do we need to use a safety plan? Same way that when I get a runny nose, I know I need to take some vitamin C, eat some chicken noodle soup, get a little more rest. I can also be trained to recognize what are my signs of distress. Do I start to withdraw? Do I start to isolate? Do I start to self-medicate? Okay, when I see those things coming on, what are some of the coping skills? What are some of this, who and what are some of the distractions? Who are some of the people that I can bring into my safety network? But again, all of these things are about empowering the individual to make a decision for safety and to choose safety. We're actually not going to do Q&A right now. We're going to in a second, because I'm actually way ahead of schedule, but I'm going to put this up, and I just want to talk a little story. I'm going to take this off. I hope it doesn't make too much noise. So let's talk a little bit of story. We can talk all day long about research, and we can talk about evidence-based. But what does this look like in the real world? So let's talk about that. I think there's a bunch of notes that I have that I want to circle back to, but I want to start by just telling you a little story about how this has impacted my life. So, as you know, I've worked in suicide prevention for quite a while. I've dedicated my entire adult life to suicide prevention. I've spent the last few years talking a lot about means safety and how to make people safe from suicide. A few months back, I found myself in what I would refer to, or what my mom would refer to, as a rough patch. I had broken my leg, so my body literally was broken. But through the course of life events, my heart, my mind, and my body also got broken. And my life was literally like a country song, I swear, every aspect of it. And one evening, to continue the cliche of the country song, I came home and it felt like the whole bottom had just fallen out of my world. And I remember sitting there by the fireplace one night, and again, as cliche as this sounds, with a bottle in one hand and a firearm in the other, wondering whether or not I should be here tomorrow. This guy who wakes up every day, tells people about suicide prevention, talks to them about being safe, I found myself in that space. And we talk about suicide as if it's some static thing. And I'd been in a lot of pain up until that point, but I had never gotten to the place where I was capable. And that night I was very capable. I held the gun in my hand, and I apologize if this is activating to anybody. I racked it a few times, made sure it was empty, pulled the trigger a few times just to make sure everything was working. And I just sat there, just overwhelmed with pain, wondering how I was going to figure out how to keep breathing. Thinking, again, not that I wanted to die, but that I didn't know how to go on living. And something very, I'll call it magical, happened. As I was sitting there, I had some music playing in the background as I was going through my thoughts. And a song came on. It's called Needle Falls Down by Charles Wesley Godwin. I want to read some of the lyrics to you. It says, time in the evening I pulled out my gun, preparing for what's after I poured something strong. I yearn for the rope and lady's sweet voice, sing me my last words, and I won't sing along. Needle fall down, sing me a song. It's been a long life and it all went wrong. Needle fall down, sing me a song. It's been a long life and it all went wrong. And I heard that song. And I remember realizing that that meant that someone else has been sitting in this chair before, next to a fire with a gun in their hand, and he decided to do something different, so maybe I should. So I put the gun down and I put the bottle down and I went to bed thinking maybe it'll be different tomorrow. I woke up that next morning and I went to my brother, not knowing how he would react. And this is another part that we have got to get over, this fear of people's reaction. Because we get feared of their reaction, so we don't do the thing. When I went to talk to him and have a conversation with him, I didn't know. I mean, I love the guy, and he's been supportive of me my whole life. But I didn't know how he was going to react. I didn't know if he was going to tease me or mock me or shame me. And that fear is what causes a lot of us from having conversations when we need help the most. And instead what happened is I went up to my brother. I told him about the night before. And he hugged me. And he said, I love you, and whatever you need. I handed him the keys to my gun. He hugged me again and said, I got your back. Whenever you're ready, you can have these back. And again, that reaction, we're so fearful of that reaction. Excuse me, I'm sorry. Damn. This is a kick in the gut. But after having that conversation, after acknowledging the danger that I had been in, because a lot of times as firearm owners, we convince ourselves that we own guns because we're worried about the other dangers. We consider ourselves protectors. It took me acknowledging that I needed to protect myself from myself to have that conversation and to realize that I had a team right next to me who was going to support me. And then I could start doing the work. And then I could start doing the work to heal, to get sturdy, to get strong again. So why the hell did I tell you this story today? One thing I've realized is that I wasn't broken, I was injured. When something's broke, it can't be fixed. And I just needed to do some work to get fixed. But the immediate danger that one item presented in my life was something that needed to change. And because of my fears of my own acknowledgement that I needed help, because of the fears of the acknowledgement or how my brother was going to respond, I hesitated. And so part of the work that I do, and again, this is after years of work in this field, is realizing that firearm owners, we need to hold ourselves accountable for our safety as well as those around us. Acknowledging that the biggest risk that we face is likely suicide. And so we need to be informed about how to have those conversations. Now the next group I want to hold accountable is mental health professionals. To be trained in counseling and lethal means, to be trained in safety planning. I wasn't going to share this part because I think mental health professionals are the chosen people, so I hope you take this the right way. But that next day after I spoke to my brother, I realized I needed to make some phone calls. I needed to get some help. I had 3 different phone calls over the next 24 hours with 3 different mental health professionals. Within the first 30 seconds of every phone call, I got screened for suicide risk. And I lied through my teeth. Because they didn't know who I was. They didn't take time to build trust or rapport with me. Their second or third question out of their mouth was, "Are you thinking about suicide?" Why would I tell you you're a stranger to me at this point? Build a friendship with me, and then I will let you in. So we have to be more willing to, and I know you're burdened, I know the system is broken and all the things, but take time to build trust, to build compassion, to build rapport. And also, we have built this fear of liability up so much within our communities, especially within the mental health community. What if I do this? I don't want to say the wrong thing. I don't want to do the wrong thing. Trust in yourself. You have taken your God-given talents to try to make the world a better place. Trust in that. Trust in your compassion. Trust in your empathy. Trust that you will know what to say. Trust that you will know what to do. But go out and get the training. Make sure that you're prepared for those conversations. And when I was working as an EMT, one of the things we called it is downshifting. Slow everything down. Realize that time is one of your best friends. Slow everything down. Sometimes the person just needs to breathe. Sometimes they just need a beat. So you need to push that fear away, and you need to let the person know that you're willing to sit in the mud with them. Because before you show us that, we won't let you in. So come, sit in the mud. There's plenty of room, I guarantee you. A couple other things I want to mention before I open it up for question. I apologize that I'm a little bit ahead of time on this. I hope it doesn't screw up the whole thing, but I guess a little extra time is better than not enough. But a few things I wanted to make sure I emphasize today. One is that we need to stop this us versus them mentality. We are loss survivors. We are attempt survivors. We are people with lived experience. We're not talking about them. We have to talk about us. We have got to take, like I said earlier, we have got to take suicide prevention out of the ivory tower. We have got to empower the average person, the average friend, the average family member to know how to have this conversation. Not just the conversation to recognize risk and refer to somebody, but that's the person that person is going to be able to go to every day. At best, they're going to get an hour a week with a mental health professional, maybe 2 if they're extremely lucky. More than likely, they're going to get 1 hour every 3 to 4 weeks. So we need to empower friends and family to understand the role that they can play. And we also need to do a better job of, when working with that individual, to help them bring those friends and those families in. Because a lot of times people cut off their connections. They pull back. We convince ourselves we're a burden in people's lives, or people would be better off without us. Help them to rebuild those connections so that they can have a network of safety around them. Earlier, Dr. Meza talked about the tragedy of suicide and how it's impacting our youth. I would say the bigger travesty of the mental health community is that we get distracted by the number of suicide deaths, not realizing that when she earlier spoke about 20% of youth considered suicide in the past year, that means 20% of youth are in that much emotional pain. That is what we should have our attention on. Because if we don't focus on that, we will never do the next step, which is actually reducing suicides. And as I've said time and time again, we have to stop waiting for perfect. We have got to get rid of the fears of liability, the fears of shame, and realize, as I stand in front of this room and just poured my soul out to you, that yeah, I've thought about suicide. So what? It doesn't mean I'm weak, it doesn't mean I'm broken. And to learn to stand with each other and have more people like me willing to stand on a stage and say, yeah, I've been there. And that's okay. Because a lot of us have, and I know for certain I'm not the only person in this room who has. And I say this frequently, but in my other trainings and my other talks, but I really do believe that there's a philosophical element to suicide that we neglect. If you go back and you read the great operas, you read Shakespeare, you go back to the great philosophers, there is a philosophical element that isn't necessarily related to mental health or mental illness when it comes to suicide. About why am I here? What is my purpose here? Why should I be here tomorrow? We need to learn to better embrace that. But to do that, I think we need to simplify suicide down. And when, again, you can go and you can read the research and you can read all the theories and all the things, but in my opinion, suicide comes down to two things, and it's pain and it's hope. And suicide happens when pain outweighs that hope. But the reality is that anybody who's connected in our lives has access to our pain and has access to our hope. And we really, truly just need to do a better job of embracing that. And so to close out, before I open it up to Q&A, I want to share a quote. There's one of my favorite books that I've ever read. It's called Care of the Soul by Dr. Thomas More. And no, I don't have any proceeds or anything from the book. It's just a damn good book. But in it, he talks, and I don't think he was talking about suicide, but that's what I took away from it. But he says, and I quote, "The Greeks told the story of the Minotaur, a bull-headed, flesh-eating beast who lived at the center of the labyrinth. And yet his name was Asterion, which means star. I often think of this paradox as I sit with somebody with tears in her eyes, searching for a way to deal with a death, a divorce, or a depression. It is a beast, this thing that stirs in the core of her innermost being, but it is also the star of her innermost nature. And we have to care for this suffering with extreme reverence, so that in our fear and anger at the beast, we do not overlook the star. In our fear of suicide, in our anger at suicide, we have got to stop overlooking the star." Thank you very much. So on that note, I think I'm allowed to take a few questions. I see one up here and one in the middle.
So I'm a military wife. My husband has guns. He's used guns since he was 18. Every 6 months, every year or so, he gets a phone call or a text, "My buddy in the unit died by suicide." Have you guys brought this to the military or to military families?
I personally have done some work with military. Most of the time that I do is voluntary. I volunteer my time. I've done, for any of you who have served, you know about safety stand-downs, which if you're not familiar with the safety stand-down, it is basically they cram everybody in an auditorium for about 8 hours in death by PowerPoint, and they talk to them about STDs and drunk driving and suicide and mental health and all the things. So I've been doing those for years, and I finally got rid of the PowerPoint and just talked to them. Unfortunately, the reality when I talk to them is I tell them, don't go outside, go into the civilian world to get your help. And the advice, as sad as this is to say, the advice that I give them, and people might disagree with this, I apologize, the advice that I give them is if you're worried about your buddy, the best thing that you can do is dig in your pocket and pay cash for them to go see a therapist so there's no record of it. Because the reality is, while the military is doing a better job at responding, I have a friend who's a commander of a unit in the Navy, where when people have thoughts of suicide, they get pulled over to that unit, but now they've been labeled the Band of Misfit Toys. I had the opportunity to present at an Admiral's Huddle a few years ago, and I got done with my talk, and I said, look, if I get a chance to speak to admirals, like, I'm going to throw all my money in the pot. And he got done, and there was a sailor in the back of the room who was absolutely courageous, and he raised his hand and he said, "So just to be clear, you say the way that the military responds to suicide risk is completely wrong?" And I said, I didn't say that, but yes, I did say that. So as far as the military goes, there are some people doing tremendous work. Dr. Craig Bryan is one of the best minds out there in suicide prevention. And I can't think of the name of his theory related to suicide, but he talks about how suicide fluctuates. So he's doing some great work. The problem with the military, or at least with my engagement with them, is that they kind of like to keep things in-house, as you imagine. So I've only been able to chip away at it so far. Now, that being said, again, I think speaking to them from the civilian side, come out and go to a civilian therapist, call the civilian crisis line, go store your firearms at the local gun shop, or some of the strategies I hope can be effective. So I wish I could do more. My greatest regret is not serving our country and earning the right to salute the flag, but hopefully help keep some of them safe. So, yeah, go ahead.
To help train.
Oh, he's training. Yep.
I'm so sorry. He's offered to, talk to people about firearms, help them get connected with a firearms trainer and things like that. So what would you suggest he could do? He's a veteran.
That he could what?
What could he do? How could he help?
I'll give you my email, and he should get in touch with me.
Got it.
Okay. Oh, it's right there. Never mind. So let's do that. But talking to his local gun shop, I'm sure he's got a spot where he goes, hey, what are you guys doing for suicide prevention? I would love for someone to, who's not there to, push it, to just be like, hey, what are we doing? And to have someone like him be willing to stand up. And again, we've got to do a better job. So I'm sorry I don't have a great answer for that right now, but I would, through part of another project that's related to the website we'll be launching, we're going to be piloting a firearm suicide prevention project that's based on the pilot, kind of the work we did in San Diego in 5 or 7 counties across the state. So maybe we can have Riverside be one of those counties. We'll have to talk about that. All right, great. Question over here. Yeah.
Yes. Hi.
Hi.
So usually in the evening I look at the news often, and it's usually the Apple News. And so what I find a few times a week is I come across news related to murder-suicides. In your work, have you noticed an increase? And if so, why do you think so?
To be honest with you, that's not an area of suicide prevention that I've spent a lot of time in. As much as the media really pushes it out there, and even though the supervisor earlier talked about his personal story that impacted him, it does represent a very small amount of actual suicides. And I can tell you that in the tens of thousands of people that I've spoke to having thoughts of suicide, I honestly can't think of one that was having thoughts of harming somebody else. So one of the messages we have to do is, I think we do a disservice by creating this narrative that if someone is suicidal, they are therefore a threat to other people. And I don't have any science to back this up, but while most people who engage either in murder-suicide or mass shootings also have thoughts of suicide, most people who have thoughts of suicide don't go that route. But if we were looking at trying to prevent either, knowing that it did start with thoughts of suicide, if we do a better job in suicide prevention, my hope would be that we could prevent some of those other types of tragedies as well. So I'm sorry I don't have a great answer on that one.
And I guess I see it around families.
Yeah. Yeah, and that's just another area where there hasn't been a lot of research. We have to do a better job in suicide prevention, looking at what are the dynamics that what's the different risk for a murder-suicide versus a regular suicide? Because I don't know, it's tough for me to imagine that they're all the same. Great question, though. Yeah.
Mr. Collins, thank you so much for the information that you shared, but you asked a question of yourself earlier, and you asked yourself, why am I sharing this story? And so I just want to kind of bring something to your attention. The whole room shifted when you shared your story. And so I want to thank you for your vulnerability, and you spoke to someone's heart in this room by sharing your own testimony. And so I just wanted to bring that to your attention because it was beautiful and we felt it.
Thank you very much. I'm trying to remind myself or forget that this is being live streamed on Facebook, so whoops. Any other questions? Yes.
Hi, I also wanted to say thank you so much for sharing your story and being vulnerable with us. And my family, I do have, family members, male family members that have own firearms. And I just think that your story is so impactful, especially for males. And how often do you get a chance to share those stories? I was thinking of my brother, my dad, my cousins, they would just, it would be so powerful for them to be able to hear or see somebody like you and see that vulnerability.
I think, was there a question?
How often do you get to share your story with?
Well, surprise, that's actually the first time I've ever talked about it, so.
Oh, okay. You should definitely do it more than that.
All right, thank you. Thank you for that call to action, and I will share. And again, I've always believed I got involved in this work as a loss survivor, and the suicide prevention field has oftentimes been led by loss survivors. Over the past 5-10 years, we've done a better job of honoring and respecting attempt survivors. but the more or equally common experience is people who have had those thoughts. And we have not put them to task to ask them, well, what diverted you? And again, I'm not saying today that suicide prevention, just hope the right song comes on at the right moment. It's got to be more than that, but we have to have more people willing to talk about it. Yeah, I've been there. And what diverted me. So thank you for that. I appreciate that. And yeah, surprise.
We have one here.
Yeah, and then we'll go to the back here.
Hi, I wanted to ask if you had this information in other languages and resources in other languages.
So the Mean Safety website will be both in English and Spanish, and then from there the Gunshot Project, the contract requirements are for English and Spanish as well, but I'm definitely open to it. I can't say for certain whether or not those materials will be adapted, specific to the firearm aspect of it. Through another project we have variety of mental health and suicide prevention resources that are culturally adapted into other languages.
Thank you.
But yes, I realize that is a woefully unacceptable answer, that this should be more available, but that goes back to resources, right? It's, yeah, I won't get on that soapbox. That's a dangerous soapbox in this room. Yeah, in the back.
Hi, I'm Dr. Jennifer Carson. I'm with Inland Southern California Crisis Line, and I'm also on the board of the American Association of Suicidology. I wanted to ask you a question centered in children. I'm a child suicide attempt survivor who survived several days of suicidal behaviors and then several decades of suicidal ideation. And I think there's some really exciting prevention happening with sexual violence with children, teaching them consent in an age-appropriate manner. And so I wanted to ask your thoughts on how we can go across the lifespan and really focus on prevention and teaching in these areas with our small children.
Wow. Well, you're the doctor. And hey, Jen, it's good to see you. Congratulations on Dr. Jen. That is a big question, and I don't know how to respond to it perfectly, so I'm going to say this. One thing that I do know is that in the work that I do, especially, if you look at the data, and 70% of suicides are deaths of males, right? And again, apologies for being binary, or those who identify as males. I would say 75% of the time when I talk to males about their lived experience related to suicide, when you peel back the layers of the onion, you go back and you rewind the tape far enough, and there likely was also sexual violence. I am also a victim of sexual violence, which hey, Facebook. We need to have more men being willing to talk about that. And that's just something that has not been addressed or not talked about. I think a lot of guys, when they go into therapy because their marriage didn't work out or they lost their job, and they're focused on this is why I feel bad now. And we got to have mental health professionals who are willing to be patient and say, okay, I know your job thing sucks and the relationship thing sucks, but let's go back a little. Let's rewind the tape. Let's rewind the tape. Let's rewind the tape. So I can't believe that was my answer, but that was my answer. And in front of a room full of people and live on Facebook, here we go. But should we be doing more in that area? I absolutely agree, especially in the male population or those who identify as males. Thank you, Dr. Jen. Any other questions or any other parts of my soul that you need me to bear in front of this room today? Sorry, those lights are blinding, so you guys are going to have... Oh, we got another one?
I just want to say, I think a lot of us are in the mental health field, and just hearing your story, when we're the professional, there's that fear of not knowing or the uncertainty, or we don't talk about what's wrong with me. So I just want to say your story really touched me, because I think a lot of us struggle with, I should be the professional, I should be not have any issues. So I think this was a great room for you to share your story, because you really touched, I believe, a lot of us. Because we are in that boat where we shouldn't talk about it. We should be the one that knows how to fix things, and we don't look at ourselves for that.
Thank you for saying that. I really appreciate that. And I didn't really dive into it, but that's part of my story as well. Again, I would wake up, I would go through those kind of nights, and then I would wake up and I'd have to go think and talk about suicide. And so I was living this imposter syndrome every day, and I was having to dive in. So I think that's one of the toughest conundrums, is not only Where do I get help? Where, you know, well, if I call the hotline, do I know the person that's going to answer the phone is one issue. But two, you know, how can we create space in our lives where, yes, this is our work, but in those moments, and I'm blessed that I have a team of amazing people that supported me professionally and understood that as I was processing this, yeah, there were days where I just couldn't do it. And there were days where I couldn't talk about mean safety because I'm literally living mean safety right now. So I hope that any of you out there, like you said, who might have been touched by that, if you're in need of support, please don't hesitate. But thank you for your kind words. I appreciate that a lot. Yeah, Pierre.
You had mentioned, like, oh, yeah.
Oh, you again.
I know. Like, you had mentioned, oh, yeah, I'm a gringo up in here talking, but I just wanted to say you're invited to the carne asada. That's it.
Thank you. Oh, is it? Okay. Any other thoughts, questions? Well, I hope I didn't screw up the caterers either, because I think, oh, no, we got questions.
Thank you. My question is this one. You mentioned that sometimes you have to accept that when you have to protect yourself from you. So how would you say that you can handle that reality?
Protecting myself?
From you. Because it is hard. For example, I don't know if I'm making sense by asking, but for example, when you do the ACEs type of assessment,
yeah.
I don't know. Okay, so when you do that and you realize all the things that had happened to you, it's a big shock. Also realizing that you are a threat to you is a big shock. How would you suggest that you can handle something like that?
Ooh.
Sorry.
No, it's a great question. I don't know. Wow. I think I probably will have a better answer for that in a year or two as I have a little more time and distance from it. But I think just waking up that next day and realizing for all the things that I've been the victim of violence before in multiple forms. I come from a family of law enforcement, so I've seen the worst of humanity through the stories that they've shared. And it just was a wild experience for me to have to acknowledge, no, the biggest danger that I have these firearms to protect my family and my friends from the dangers. And a lot of people don't understand this about firearms. It's not that I or other people have firearms because they hate what is in front of them. It's because they love what's behind them. But I needed to understand that the biggest danger to the things behind me was me not being here. And so I think for me, part of it was acknowledging that, and also the reality, yes, community violence is real. Again, having been a victim of pretty intense violence in my past, to set that aside and realize that if that is needed, there are other ways for me to defend myself. Like when guys, I don't mean this to sound dismissive, but when guys say, well, how will I protect my family if an intruder comes in your home? My response is jiu-jitsu, bro. Like baseball bats. Like there's other things you can do. In the wildly unlikely event that someone actually breaks in your home, there's other things you can do to protect yourself. But if that firearm is presenting a danger to you, then you need to get it out. Again, not forever, just for a while. And when I went back to my brother and said, hey, I think I'm good, can I have him back? He said, yeah, I think you're good too, because he saw the process. And so that's another part, is people won't get rid of the guns because they're like, well, what's the process for getting them back? Is that going to put liability on the person for returning them back to the home? The person that you're going to ask to hold on to your guns is going to be so tightly tied to your life for that period of time. They're going to know and they're going to see. They're going to know when you're safe just the same way that you're going to know that you're safe. So as far as, I don't know, I'll still get back. I totally evaded your question, I think, somehow. But I'll get back to you. Thank you. Another one in the back.
Hi, I just want to say thank you for sharing your story again. You touched on the penal code and on gun ownership rights. With the data that 90% of attempt survivors don't go on to die from suicide, what are your thoughts on the 5, 10 lifetime bans on gun ownership? And as a gun owner yourself, do you think that needs to be revised based on the data that we have? Or do you think that those things should not be a priority right now?
Ooh, that is a loaded question, but I put myself up here on this stage, so I think I have to at least take a go at it. I guess and there's other parts of firearm ownership that I don't necessarily agree with the average firearm owner on. You know, the high capacity things and the rifles and all the things. There's certain things that I'm different in that regard too. As far as, I think the GVRO, things like that can be useful tools. I think the 5 and 10 year bans and such can also be useful tools. But again, I think that we're evading the actual issue. The actual issue is, how do we make firearm owners understand that part of your duty as a firearm owner is to not just protect other people from getting access to your guns, but protecting yourself from access to those guns during times of danger. So I would rather look at other options that might be more real world, without like real world application, that don't take people's rights away. I would rather explore all those options and see what we can do before putting more laws out there. I don't know if that's answering your question, but I'd rather have the accountability be on the firearm community. Now, if they don't show up and they don't support, like one of the things when I was working with these gun shops, is I tell them, like, look, if 60% of firearm deaths are suicides, even if not for a moral reason, from a business standpoint, doesn't it behoove you to support suicide prevention to reduce firearm suicides? Isn't that, if for no other reason, going to take the heat off your industry a little bit if we can reduce the firearm deaths overall? So, I don't know, I think I'm evading your question again. But I'm more of helping people to want to be accountable and want to keep themselves and people in their lives safe than more mandates and laws, I guess, is the short version. But sometimes laws have been really effective. Like there was a law a few years ago that now requires all schools in California to do suicide prevention. It's been a complete sea change in school-based suicide prevention. So sometimes laws can do great things. All right. Any more hands out there? On that note then, as I turn it back over to your host today, I just want to say thank you for the kind words and the support, especially for those that called it out specifically. Thank you for being my first time sharing that story for my coming out party. But also just thanks for what you do. Again, the most important thing I'm going to ask of you is the same thing I asked when I first started. Please take care of yourselves. We use the whole, oxygen mask mentality analogy all the time. It's cliche by now, but just take care of yourselves. This is tough work that we've decided to do. This is a tough day that you've decided to attend. I hope when you're done today or during lunch, you'll take 5 minutes, go see the sun, get some sunshine. Tonight when you're done and you get home, take a bubble bath. If you need somebody to hug you or tell you that they love you, please ask for that. But thank you for holding